Okay, are we live?
Yes, ma'am.
Good morning, Wyoming. Good morning, committee. Here we are back again for our second day of the Joint Labor, Health, and Social Services Committee of the Legislature. We had to carry over a few items from yesterday. We're going to just work them in. I don't believe we need to call roll because we just recessed from yesterday, and the majority are still back again. LSO, is there anything that we need to consider before we hear from Representative Larson?
I do not believe, ma'am, there's anything from LSO at this time.
Okay. Do we have anything that might have been, well, I'll ask Representative Larson himself because there he is. Representative Larson, should the committee expect anything by email or something that might be a potential legislation to consider? Has that come out to us? You're muted.
There you go. No, ma'am, we'll discuss that as we.
Okay, all right. Well then, welcome Representative Larson, a former member of our committee. We miss him, even though it's been kind of a lot of years by now, but I miss him anyway. And he has been the House Chairman of our Joint Committee on Mental Health and Substance Abuse, which many of us on this call are also members. I am Representative Barlow, Senator Bouchard, and Senator Schuler, I believe. So some of this will no doubt not be new to you, but the more people we here to understand it, the better. And if there is potential legislation coming out of that, I believe we're probably the appropriate committee, unless it's very related to appropriations. So welcome, Representative Larson. Go ahead and give us an update.
Thank you, Madam Chairman. And I would just follow up to your introduction by noting that on the Appropriations Committee side, the Senate side, we had Senator Guru and Senator Kinski, and then on the House side, myself and Representative Jared Olson. And so, Madam Chairman and members of the committee, the genesis for this subcommittee, as you will recall, is to look at the cost and the delivery of mental health and substance abuse in the state of Wyoming. And just as a reminder, I would point to a handout that you received, I believe, in your Labor and Health meeting in May, in your May meeting, where it identifies that our funding for community mental health and substance abuse appropriations for this biennium, sum total is about $96 million, close to $97 million. 81.4 million of that is general fund dollars. So if you then look at that and you go to our statutes, which are largely found governing this, the delivery of mental health and substance abuse in 35.1 Article 600 and also in 92102. Title or 92102 is really establishes the Department of Health and makes a requirement for the Department of Health to establish minimum standards for human services. Then when you get over into Title 35, it's the that is the community mental health services, and that section is really broken into two pieces. Half of it allows the communities, the counties, to enter into contract for human services with any entity that they can get funding through. The last half really points to the Department of Health and how they would enter into contract with private entities to provide human services, of which mental health and substance abuse is part of. But as you try and figure out and go through those statutes, what the delivery model is and what the policy of the state is, I think it becomes difficult to find that. And so the goal of this subcommittee, as we met, was really to determine what the policy of the state is. And to determine that, we ask the question, what's the role of the state in providing mental health and substance abuse services to the state? And if you currently look at our delivery model with our community mental health providers, I think that you would see on a scale, Madam Chairman, as you recall, if you had a scale showing general access, meaning everybody that wants to receive any type of mental health or substance abuse would be clear over on one side of the scale. And then having the state be a safety net, meaning the very minimum, if all else fails, you can come to the state, or this, if all else fails, the state would then help provide services, being the most restrictive side. And we currently have a delivery model that's somewhere really close to the middle of that. And so is that where we need to be with the funding that we have, and so that kind of comes back to this committee trying to determine what the policy of the state is. I think the first task that this subcommittee needed to get out of the road is what is the role, is it the role of the state to provide all of these services, or such as, to be clear, meaning that the Department of Health or some other agency would take the place of our community mental health providers, and we would take all of that burden on in state government. And the in our meetings with WAMSAC and in the meeting of the subcommittee, it is, my opinion was that clearly came out that it is not the role or the appropriate role of the state to enter into providing all of those services, that the model we currently have seems to be appropriate. However, we do need to define what the role or what the policy of the state is. So to determine that, Madam Chairman and members of the committee, we kind of had a couple of, or we had at least one a little bit unconventional meeting where we followed a exercise that the Department of Health had internally, and also one that they had with WAMSAC, the providers that, and a number of the providers that deliver these services to the citizens of the state. And as a subcommittee, we looked at all of the services that are provided through the Community Mental Health Network, and we then individually reported to the Department of Health. Senator Beauchard, myself, everybody who was on that had to make a voice and say, these are the populations that we think need or should have access to mental health and substance abuse services in the state. And then then we took all of those populations and we put them into various buckets. And there's actually 7 of those. And as a subcommittee, we looked at those services provided, and we feel the expectations or deliveries are not well defined. We should consider establishing a policy to define what the populations of the state's funding should focus on and the intended outcomes as a result. The 7 categories or buckets that we defined were those that are involved in state institutions such as the Department of Corrections, Title VII commitments, high needs in children or court orders through Department of Family Services, diversions into institutions, preventing recidivism into state institutions, and providing gatekeeping services to do those same things. The second bucket was justice involved in non-state institutions. And again, that's people that are involved in generic type corrections, meaning local jails and county and cities, and preventing recidivism there. Acute psychiatric individuals, people who are at risk of being under Title 25, people who are in psychiatric crisis, and people who are suicidal. Our fourth bucket are those citizens of the state with mental illness that have an inability to pay and have high needs. So these are the people with serious and persistent mental illness, and those are that's generally the population that we need to be able to maintain in the community, but to prevent being put back into a state institution, and they don't have the means to pay. The other section of that is the high needs substance abuse population who do not have a means to pay. Then the other bucket that has the inability to pay are homeless and indigent folks, underserved or unserved, and those without social supports or networks. Then our sixth bucket was preventive maintenance or case management. The need to help our populations in that area. And then the last one, of course, was general access. And general access really surprised me because I was surprised at the support that had. But in reflecting on that, that really comes back to the more rural parts of our state who may not have any other source of mental health or substance abuse services other than those provided by our community mental health providers. So then what we did, Madam Chairman, as you recall, is we took all of those, and this subcommittee went into a second exercise, and we said, if you take all of these buckets now and the populations that are in them, and you've kind of set everything aside, meaning that's just kind of disregard funding requirements, disregard current statutory requirements, but if you had to take 100 points and identify which of these are the most important, and could divide your 100 points in there in proportion to importance or priority, how would that look? And the priority from this committee's effort came back that the top priority would be the justice involved in the state institutions and non-state institutions. The third was the acute psychiatric. The fourth was the inability to pay. Fifth was inability to pay and high needs. The sixth was the preventive case management, and seventh was general access. And that was kind of broken down, the first two at 25% each. Actually, the first three at 25% each. And then the next three at 10% each, and then the last one, no, I'm mistaken on that. The inability to pay was only 3%, and general access was 2%. And so, with that information, Madam Chairman, we've determined as a subcommittee that with that information, if we were to say to the state, the citizens of the state, our priority in funding community mental health and substance abuse services with state general fund dollars, we would focus in priority those that I just mentioned. And we think that it's going to probably take a couple of exercises this year and maybe following up next year to get everything completely into place. What we proposed as a subcommittee was to work between now and your next meeting to go through 35-1, Article 6, and look at those statutes as well as the other statutes that are applicable to providing mental health and substance abuse services through our community mental health service, and bringing some of those that are associated in corrections, and look at those statutes and make sure that there aren't any conflicting statutes that would require change to allow us to focus on these priority populations, and then put into statute a system to focus on those priorities. How that is going to look, we've not completely fleshed out. Our meeting was last week. We're working with LSO to do that. I don't know if that will be a tier system. The question that kind of comes out is how prescriptive should our statutes be? Should we say that that 25% of all efforts should go towards justice involved. I think we all have a little bit of concern about getting real prescriptive on that. However, in visiting with the Department of Health, they say that having some description in what those priorities are is beneficial to them and to the community mental health providers, because it takes some of that guesswork or discussion out of the contract negotiations or contract portions that the community mental health providers then don't come back and question, or that this is just or that there's the appearance that the contracts are a product solely of those in the behavioral health division of the Department of Health. And so we want to give them a little bit of direction to base the discussion of the contracts on. You asked or you suggested that this would probably come back to the Labor and Health Committee, and that is indeed the intent, that we'll have something here in the next couple of weeks that we will review with the subcommittee, and then have something for you to consider at your next meeting. In fairness to the process, we hope that we can have something put together that is that you're able to chew on and digest in that meeting, but it may be something that you feel needs to carry on into the session. So, but anyway, it'll be the start of the process, and we'll defer to you and Chairman Scott on how you would proceed with that, even or if you considered what we present to you worthy of carrying forward. So we're just, I think this subcommittee has really just tried to shift the wheat from the tares, if you will, a little bit, and try to identify really and this is a discussion that we've been having for a number of years, and much of the information we had are handouts that you've had over the last 2 or 3 years, and we just kind of gone through that and focused more on this. I will also tell you that, Madam Chairman and Mr. Chairman, that I participated in a couple of discussions with the Department of Health as they engaged with our WAMSAC group on this topic as well. I think that I'm certain that they'll give their opinion on this process in public comment. But my takeaway from what I am hearing, plus what I am seeing here, is that they too would acknowledge that further definition on what the state's policy for providing these services would help them better deliver and understand what their business model should be. I think next year, as we go into interim, the big discussion will be then how, if we set these priorities up, then how do you establish eligibility and reimbursement back to the community mental health providers? I would also, excuse me, Madam Chairman, I would also just share with the committee that it's been my experience on that committee and similar committees where my suggestion that this might take a couple of years to get everything into place is not really an anomaly. We've done that with the long-term care rebasing for the nonprofits and the and for-profit long-term care facilities. We've done it for the state health facilities. We also done the effort we made in redoing our DD waiver into support and comprehensive. Took a couple of years to get that to where everybody was pretty well on the same page, and I think this exercise will follow that to some degree. So with that, Madam Chairman, that is my report, trying to make it as brief but yet informative as, and how well I succeeded on that remains to be seen.
Well, we'll see how many questions there are. Any questions for Representative Larson? Chairman Scott?
Multiple questions. Particularly on your last bucket, the sort of the general needs of the community for mental health services. To what extent do the centers have private sources of funding that can meet those needs?
Madam Chairman.
Representative Larson?
Thank you. And Chairman Scott, I think that's a great question. And I think that what we find is that varies around the state. It's not unlike the rest of our healthcare delivery system in those areas where you have a population and have the numbers that, and maybe have the industry that has insurance. You have some access to private pay, to company insurance or employee insurance, as well as Medicaid. And you get into some of the more rural areas, and the ability to pay really then shifts just down to private pay, and if they have private insurance. But the bigger question on the general access, I believe, Senator Scott, is in some of our more rural areas, do we have any other mental health providers? Now, that doesn't necessarily mean that if our community mental health provider is the sole provider in a county, that the state has to provide service, or that the services provided would be funded by the state. I think, though, that you would see the need perhaps by the community health provider in maintaining its infrastructure, administrative costs, and that might have to be funded a little more out of this the state allocation over those facilities maybe who have larger populations. And I think, if I may, Madam Chairman, and back to Senator Scott, is I think it's really important is if we prioritize, as we look at this prioritization, we're saying that I think that one of the things that we're going to have to say is that or realize that if our priority is on population A, then there's going to be less of a priority on population D. And so those fundings that may traditionally have been available equally to both populations may shift as we determine eligibility in that.
More questions for Representative Senator Scott? Did you have a follow-up or another question?
Madam Chairman, no, it's not a follow-up, but a different
No, go ahead.
question. My perception is that the group that you identified in your bucket as people with serious illness but an inability to pay, or serious substance abuse needs and an inability to pay, is larger in the mental health area than it is elsewhere, because the mental illness or the substance abuse problems tend to prevent people from being as gainfully employed, and interfere with their ability to hold down a job. Is that true, or do we see a distribution of ability to pay that is more similar to what we see elsewhere?
Representative Larson?
Thank you, Madam Chairman. I don't know that I have the numbers to give you a definitive answer, Chairman Scott. However, I would suggest to you that as we look at those who come out of institutions or out of being titled, or people that are in our community that have these, the trick is, how do we keep them engaged in the community, living on their own and on their medications, similar to what we have with the patient-centered medical home, where we maintain them to prevent high utilization back in the healthcare system. and in this instance, high utilization back into a state institution. And so as the priority came back on that, there was a significant allocation for those who show those persistent mental health challenges in the, it's our third bucket, the acute psychiatric or fourth bucket, I'm sorry, the inability to pay and high needs. So I think that there's we recognize the need to be able to address that, and in doing so would logically then save the state money by keeping out of other state institutions.
Any other questions for Representative Larson? I'll circle back to you in a minute, Senator Scott, after I see if anyone else has anything, which I don't actually see any. Go ahead, Senator Scott. Oh, Representative Barlow, let me just call on him.
Thank you, Madam Chairman. So my question for Representative Larson would be, post the subcommittee's meeting and in visiting with Department of Health, are there any budgetary, what does the budgetary vision look like for substance use mental health? Meaning, subject to the 5 or 10% we've already dealt with, what is, you getting any sense of what that might bring to the conversation? Thank you, Madam Chair.
Representative Larson.
Thank you, Madam Chairman, and Representative Barlow. At this point in this process, in trying to, we've resisted throwing a loop around that discussion on funding for services, just so that we could say, before we get the influence of money in here, what is our policy? Let's get a pure policy out there. And then once we've determined what that is, and I think Representative Barlow, although that has come up to some degree, I think that we would say that we resisted how to allocate those dollars and how to make adjustments on those dollars. We're just trying to establish policy at this point in the exercise. And then as we move forward and have that discussion on eligibility and others, I think that is going to influence allocation of funds. And logically, to me, Representative Barlow, that's the importance of establishing priorities, because as funding goes short, like everything else in a budget, you try to ensure that you fund the priorities most important first. And so I think that that'll be fleshed out as we move forward to a greater extent.
Senator Scott.
Madam Chairman, question along the same lines that Representative Barlow was asking. I don't have a good fix yet on what extent we're going to have to just plain cut budgets in this coming session. And I've been wondering, do we have the luxury of a multi-year process here? Because what we do in this coming general session may settle a lot of things. And it would be useful to have it informed by some setting of priorities. So my question is there a sense that we're going to have to make much deeper reductions in this coming session? Some of the projections I've seen would certainly indicate that was true. And how do we take work of the subcommittee and use it to inform what we're going to have to do in January and February?
Madam Chairman.
Representative Larson.
A little bit of a philosophical discussion, or an interesting discussion, and your question, I think, is spot on, Chairman Scott. I think that the question back to the citizens of the state is, are you as citizens of the state comfortable with having services provided by state government that may potentially reduce significantly services that we've had in the past. If you look at the developmental preschools, you look at the DD waiver, the impacts that this initial cut has had on them, which mental health escaped the first round. But as you see further cuts, those are going to become much more enhanced and more acute, and mental health will have to participate in those cuts as well. So then the question comes back to the citizens: is this acceptable? And then if it's not acceptable, what is their expectations of the legislature to, in addition to finding ways to reduce the impacts of state government on the budget, what can we do to generate new revenue that will allow us to provide essential services to those people, these populations that suffer from these type of illnesses or disabilities that may get severely cut. And in addition to that, as we cut these services, are we saving money? The question I think is worthy of asking is, will we be saving money, or will we see some of these populations by nature then drift into more expensive state facilities and end up costing the state more through an effort to save money?
Chairman Scott.
Madam Chairman, that is sort of a good part of my concern here. We're perfectly capable of seeing a cut made that will increase our expenses down the road. I think the preschool DD cut just did that. And we'll pay for it in special education in the K-12 system big time. I'm a little scared that if we can't be more specific by the time we go in session, we'll get some reductions here that will have the effect of ballooning our Title 25 or our recidivism rates particularly with the prison substance abuse issues. So I guess I'm trying to say, I think there's some real urgency in getting some decisions made and some priorities set before this session, but I don't yet have a good fix, Madam Chairman, on how urgent it is.
Well, and if I may just throw in here, just as a member of that group, but also in general, as a legislator through the interim, I feel like the value of a process like this is it brings out a little bit more to the citizens, not just the usual people who call in, but if there's publication about this sort of thing and all, people really are confronted with what are the services, who are the people receiving services, and what do all the citizens think? Because it's pretty easy for the legislature, who is very involved with the budget book, and that doesn't even include all 90 of the legislators, frankly, to look at the budget book pages and say, okay, here's the recommendation, here's what we're putting into the budget, or here's what we'll go here. And if the citizens, if all they see is fine, here's the end product, then it's easy for people to say, well, no, you shouldn't. And this, we all get emails along this line all the time. Yes, you should cut the state government, but you shouldn't cut my program. And so if we really lay out what these programs are, it becomes a little more difficult for people to say, save education, save DD, save mental health, save substance abuse, save judicial reform, but cut $1.5 billion out of the budget. So I think that, I think you're right in the sense that we may have to draw some conclusions from this, but I think as we spread it out for broader discussion, we'll get better understanding and better participation and really more judicious conclusions drawn not only by the legislators, but by the citizens of the state. Senator Scott, I think you had your hand up again. Somebody else? Nobody else? All right. We did have, if anyone wants me, I won't fill up your inboxes with too much paper. But you remember at our last Labor Committee meeting, we had that rather lengthy report from LSO that summarized all kinds of funding in all the different areas, the different programs. So before our last subcommittee meeting, what I did was I stuck that all in an Excel file and made a colored pie chart. And if any of you want the visual aid on where the funds go in broken down by, inpatient mental health, outpatient, substance abuse, various things like that, just let me know and I'll send it to you, but I won't send it unless you ask for it. Okay, well, I guess that's all we have from Representative Larson. So we will look forward to further. So I didn't quite understand, and maybe you haven't really determined whether we should actually expect a bill draft at our November meeting or not. And maybe you haven't decided.
Madam Chairman, if I may, two points. First to yours is yes, you should. I took from your previous question regarding that as if we had anything available for you today, which we do not. But our intent is to have a bill draft for you to consider at your next meeting. And to Senator Scott's point, and for respect of this committee and the direction or the subordinate position I feel this subcommittee has to this committee, we will try to also incorporate at least some mechanism there that would give us some direction on in light of the possible revenue situation and additional cuts that would at least give us some sense of policy and direction on how we could do that in an appropriate manner. So I'm hoping that we will have time to move it forward into another year, but we with his subtle request, we will try to have something a little more in depth than what I had originally planned. So
very good. Thank you, Representative Larson, and you're certainly welcome to stay on. We expect after this to hear agency reports on their budget reductions, a statement which we hope the Appropriations Committee would also get from DFS and Department of Health on what the federal minimum requirements are for match and maintenance of effort, just to make sure that as appropriations goes forward, we don't cut in that has a bad way there. So you're welcome to hang around and listen all you like.
thank you, Madam Chair. If I could be excused, I've got a meeting with the EPA looking at illegal solid waste dump sites.
Well, there you go then. Have fun.
Thank you.
Thank you. Okay, let's see. Elizabeth, are we ready? Is the governor's office ready to present?
Ma'am, we actually did have public comment on the.
Oh,
yes.
public comment. My bad. I'm not improving much, am I, from yesterday? Okay, public comment on the joint subcommittee.
The first individual we have in our list is Mr. Byron Oderkoven.
All right, let's hear from Mr. Oderkoven. Welcome, Mr. Oderkoven. Your dots are still going up and down, so maybe you can't hear us yet. Welcome, Mr. Oderkoven. You're muted still. There you go.
There we go. Thank you, Madam
You bet.
Chair.
Glad to see you.
Thank you. A quick comment, if I may, and thank you to the committee. We were asked to participate in the subcommittee work, working on the issue of mental health. Oh, excuse me.
You're muted still.
Interesting. Can you hear me now?
Yeah, the issue is if you were listening to us on the YouTube live stream, you have to shut that off while you're talking to us.
Very good. I was. Thank you. Byron Odekoven, the Executive Director for the Wyoming Association of Sheriffs and Chiefs of Police. For comment this morning, I want to say a thank you to Representative Larson for covering the issue and discussion of the subcommittee. We spent quite a bit of time working through several concepts, several issues relating to both the outside and inside of detention, if you will, as part of the discussion. And it was clear that we were making great strides in an overall understanding of the needs at both the county level and the state level that are important to the idea of mental health, especially from my perspective, for those folks who are in danger to themselves and others. And secondly, the group that needs mental health assistance to change from their criminal behavior to that of leading a law-abiding life. And so it's important as we go forward, especially in light of budget cuts and our budget dilemmas that we have, to recognize that those two groups will have some companion costs associated with them. If we don't deal with the criminal thinking group, so to speak, we end up with more crime. If we don't deal with those that are in danger to themselves and others, we have some very serious situations and events that occur throughout the state. So it's important for those two concepts to be considered as we look at our budget cuts and how best to deliver service out in the community and within our institutions going forward. So with that, Madam Chair, without a specific bill in front of us to comment, just want to recognize the good work of the committee and to offer our support going forward as we wrestle with a serious issue at hand. Thank you, Madam Chair.
Very good. Any questions for Mr. Odekoven? I see none. Great. Thanks very much. We certainly expect you to continue participating.
Thank you, Madam Chair.
All right. Okay, Elizabeth, anybody else?
Yes, ma'am. We have Andy Somerville as our last person for this public comment.
Okay. Good morning again. Well, not again. It's more. Yes, it is morning again. Thank heavens. As the governor likes to say, the sun will still rise. So here we are. The sun has risen again and we're in Labor Committee still.
Thank you, Madam Chair. And here I am again.
Here you are again.
Andy Somerville, Executive Director for WAMSAC. And I just wanted to make a few brief comments. Start by thanking Representative Larson and the committee for their work. I think this has been a good exercise to go through for DOH, for us, and certainly the committee dedicated quite a bit of time to going through an exercise to kind of look at what we think the system should be providing. Just a few brief comments to start off with. The system that was brainstormed both by the DOH groups, work group, and then with the subcommittee is not drastically different than what we have right now. So that was an interesting outcome. We weren't sure how that was going to kind of factor in, but it's really not much different than we have now. We're serving those populations that were described by Representative Larson right now through the community mental health system. I did want to make a comment just about general access. As it was described, general access ended up being the lowest priority when we went through the exercise with the subcommittee. And a couple of things we want everybody to keep in mind is general access is important for the first reason would be we have to get them in the door and do an assessment to figure out where they actually need to sit in the system, which buckets they fall in per se, or what their eligibility is. So that's going to be an important component as we go forward, just to be able to assess people and get them in the door. The other thing that we've had some conversations within our group and from the community mental health providers as we move forward is it's important to potentially bring in and talk with the cities and the counties after we've got some legislative priorities, because I think different communities will be affected differently by those priorities. It's pretty hard to apply a one size fits all across the state, given the differences in the communities and the differences in the demands from the centers. And so we'll want to make sure we're including them in those discussions as they go on. And then the last comment is just in terms of any bill language that may come forward to the committee. We did spend some time talking with the subcommittee about how prescriptive that language should be or should not be. We do have some concerns about the language. If it's overly prescriptive and we put it in statute, we all know how hard that is to potentially change. And we believe that it's best seated with Department of Health to give them some flexibility to respond to changing priorities over the years, because we do assume that those will change. New needs will show up, others will be maybe handled a little bit better, and maybe can be less of a priority, but we need that flexibility, and we do feel comfortable with Department of Health having that flexibility. So with that, we're waiting to see what comes out from the subcommittee in terms of legislation. I think we can have a more detailed conversation at that point, but I'd stand for any questions.
Andy, I do have a question sort of following up on Co-Chairman Scott's question of Representative Larson. And I appreciate you may not have numbers or anything in front of you. We didn't have anything for the subcommittee particularly, but do you have any sense that the payer distribution might be different for the general access population versus, say, the acute psychiatric or justice involved? In other words, are people who are maybe in rural areas and looking for general access services, are they more likely to have insurance or other ways of paying, or is the rural population kind of underinsured and might be subject to the same challenges as the other buckets in terms of payer? Did that make sense?
Yes, Madam Chairman, it did. And I'm not sure that I can give you a good answer to that yet, but I will find it. My overall impression is generally it's pretty spread out in terms of who has ability to pay and who falls in those buckets. So I will get some more detailed information to bring back to the committee for that question, both to the subcommittee and to you guys. I will say also on the subject of payer, though, our rural centers, our smaller centers, the state contract makes up sometimes 65% of the center's budget. And so we are concerned about how any changes to the system may impact that. And again, that brings back in that question about general access, about a rural differential, kind of all of those specific details that we need to discuss, after we have an idea of what the policy might be.
Questions for Ms. Somerville? Okay, great. Thanks very much.
Thank you very much.
I expect you'll be lurking about for much of the rest of the day. All right, Elizabeth, who have we got next? Anybody?
Ma'am, that is all we have for public comments on the mental health update. We do have Miss Jen Davis if we are available for her next.
Yeah, why don't we go ahead and let her, she may want to hang around, that being her bailiwick, but we'll let her give her report. Good morning, Ms. Davis. Oh, you're on mute, but you're welcome into the committee meeting. You're muted still. Oh, there we go. Oh.
Morning, Madam Chair.
Good morning, Ms. Davis.
Hi, I will give you all, my report is short and sweet, so I will take any questions as you have them. I just wanted to give a brief update on the bundled payment legislation. There has been a consultant hired, Aon, which is the consultant doing the work with EGI and Cigna. They have requested the raw data claims from Cigna to start doing their analysis, which they are in the middle of doing right now. What they are looking at is specifically at episodes of care or courses of treatment that they can consider across providers in different settings to really get an understanding of where they could utilize this bundled payment concept within the system. They also are looking at the outmigration as they're looking at these claims, which we know has been a big concern of healthcare going outside of our state boundaries. So they are looking at that and looking at ways that they might be able to incentivize care for staying within the state. And then finally, the thing that they're currently exploring is looking at a third-party administrator that could help them with negotiating discounted rates and doing this bundled payment system, who have had some experience. They're particularly looking at doing that with Ivinson Hospital in Laramie, CRMC in Cheyenne, and Casper Medical Center. So basically their next steps will be determined about what they decide to do with this third-party administrator, because then they will kind of guide next steps moving forward. So that is currently where that is at.
Super. And what is the due date for their report or various steps of their report?
At this point, I'm sorry, Madam Chair, there is no specific due date from Ralph as he reported to me. They are right now just working on determining this third-party administrator. And then from that point, they'll be able to put some timelines forward of how they're going to proceed.
Okay. Questions for Ms. Davis? Representative Stivar.
Yes, ma'am. Chairman, Ms. Davis. The governor sent $5 million of the CARES Act money over for mental health the last meeting. Can you let us know how that's been spent or what's going on with that?
Ms. Davis. So this is not specific to the bundled payment, but seeing as we have you here, Ms. Davis.
Sure. Madam Chair, Representative Stivar, the governor did put $5 million aside through the SLIB board for mental health. And so right now our office and Department of Health are working on a distribution plan for that. We've had several ideas come forward, but figuring out how we can get the funds administered in this short window that we have by the end of December. We're looking at the way that we can get that distributed out as soon as possible. So hopefully we will have some of that money going out here real soon. We've been working really closely with WAMSAC to determine a best course to really get the supports where we need them. So hopefully we'll be talking about that actually today with Department of Health on our call about where we're at on that.
All right, thank you.
Chairman Scott.
Madam Chairman, my question is back on the bundled payments. Purpose of the bundled payment effort was to try to find a way to reduce the expenditures in the state employees group without adversely affecting the services they get. And my question, fairly basic one, do we know how the state employees group compares with other large groups in the state in terms of what they cost when you consider the age ranges and other factors like that? My perception is we have an extraordinarily expensive program and very much in need of things like bundled payments, but I don't know that. Is that an area, how do we compare, and is that an area we really need to be concerned about in budgetary terms?
Ms. Davis.
Madam Chair and Co-Chair Scott, I do not know the answer to that. I think what I was told from Ralph is that, they're looking at a variety of different claims that have gone through the EGI system through Cigna, but I do not know if they're looking at a cost comparison, but I can certainly get an answer to that and get back to you.
So regarding that, we, in some of the data, some reports on other subjects that we get from Department of Health and that we've received in the past, we have we are participating in the multi-payer claims database, which enabled us to look at some of the prices for the state, for other businesses in Wyoming and in Montana. In the last session, we were not successful in putting the membership for that multi-payer claims database into statute, and it wasn't in the budget. Are we still participating in that in any case by rerouting other funds, or have we lost that source of data?
Madam Chair, it is my understanding that we've lost that source of data, but I will also follow up on that as well.
Okay, thank you. Chairman Scott.
Following up on that, we did, now this was a number of years ago, there was a database that Hank Gardner was managing, and now unfortunately the late Hank Gardner. But that compared, was very interesting, compared Medicaid, state employees group, and the largest private insurer in the state. And in terms of total cost participant, Medicaid was far and away the most expensive. Despite the fact that rates are lower, they were encouraging excessive utilization. The state employees group was intermediate in that, halfway between that and what the private insurer was, and the private on a per member basis, the cheapest. And the thought at that point was it had to do with some of the incentives in the different systems, and but that's why I'm fishing for how much is the state employees group costing us compared to others, because the bundled payments is just one initiative, and what I'm wondering is do we really need to look at this area much harder as we try to get our budget under control?
Was there a question in that, Chairman Scott? I didn't quite decipher that.
Madam Chairman, the question comes back to the one previously asked, just how we compare with other groups, because I think if we knew that, we would then have a much better fix on how urgent getting more cost controls, more effective management into the state employees group was.
Do you know, is the consultant planning to look at comparable public plans across from other sources?
Madam Chair, I do not know that, but I will also ask that and follow up with you as well.
Sorry to give you such a to-do list. I know your to-do list is already rather lengthy. and so I do have one follow-up question. I believe appropriations is also considering employees group. Is there further follow-up that they are getting from you? I know there was testimony from Mr. Hayes. I don't think you were there, but on the public plan earlier this year to appropriations. Is that something that is continuing, or were they kind of done with you?
Madam Chair, I have not heard anything else about it from our office, but I can also follow up with Erica Legursky in our office, who does a lot more work with ANI than I do.
Okay, all right. Any more questions for Ms. Davis? Senator Schuler.
Thank you, Madam Chair. Just wondering, Ms. Davis, if, and again, you probably don't know yet because you've got this consultant, it's probably recently on board, but I know CMS has launched a new voluntary bundled payment model, and I think it has some potential, because I think the thing that I looked at, it has an opportunity to generate revenue through a 5% bonus payment. So I'm just kind of wondering if that consultant might take a look at that model and see if there's some potential savings there. I don't know if you guys have looked at it at all or not, but just wondering. Thank you.
Ms. Davis.
Madam Chair, Senator Schuler, I will follow up and ask if that consultant, Aon, is going to be looking at that. But that is something that is on our list to look at for the governor's task force that's looking at healthcare costs in Wyoming. And that is something that we'll be working with the group that is helping us out of Baylet Health. Those are two of the things they brought forward with bundled payments and value-based care. So we will be investigating that as part of that initiative.
Very good. Any more questions for Ms. Davis? Excellent. Thank you so much for being willing to come on. We just didn't want to think that we don't want you to think that we forgot all about our bundled payment bill.
Thank you, Madam Chair. Thank you, committee.
Okay. All right. Committee, we will, rather than interrupt in the middle of corrections and family services and whatnot, let's go ahead and take our 10-minute break now, and then we'll come back and just really dig into all of the agency reports. So we'll be back at 9:40. Good job to people who are back in a timely way. Elizabeth, looks like we're basically back. Do we have Department of Corrections with us?
We do, ma'am, and I will admit Director Shannon now.
All right. Good morning, Director Shannon. Welcome. Glad to see you. You're on mute, but you can unmute yourself and tell us about your sad budget reductions.
Good morning, Madam Chair, Chairman Scott, and committee members. I'm Dan Shannon, Acting Director for the Wyoming Department of Corrections. Thank you for having me this morning. Madam Chair, we were scheduled, with your permission, we were scheduled for a brief report on bulk purchasing, hepatitis C, a mental health substance abuse update, and as well as budget reductions.
Yep, we'll hear them all.
Okay, I clearly heard your message at the conclusion of yesterday's session, and I'll be brief as possible and very poignant. I'll stop at each section, Madam Chair, for questions.
Okay.
I will begin with the bulk purchasing. I won't regurgitate. The report was completed by the Department of Health, which I'm very thankful, Mr. Von Fruits and Deputy Johansson. They submitted a very detailed report, and on page 41 to 43 of your report, he presented two options for the Department of Corrections. One was group purchasing, and one was the subscription model. Department of Health clearly indicates that they don't believe that either one is profitable for the state of Wyoming or a department. And I have to, as the Department of Corrections, we have to agree with them for a number of reasons. We're too small. Our purchasing methods cannot be competitive with Medicaid, things of that nature. However, we learned some valuable lessons, and I was thankful that the study was completed. We're doing business a little different way, and I'm making some changes. And what I mean by that, Madam Chair, is when we currently have a contract with Horizon Medical. That contract is completed June 30th of 21, and we'll be RFPing at the first of the year in January of 21. The RFP will be submitted. We have quite a combination of the subscription model, which the Department of Health defined as a buffet style. In our current contract that RFP that we were going to put out there, which was stopped because as a result of COVID, we had the conclusion to complete and treat all of our hepatitis C. What we did learn during our last RFP, which was canceled, and I'll explain that. What we learned was 2 of the 8 applicants, they submitted proposals separate for pharmaceutical only, which brought other pharmaceutical companies in. Now, I've had discussions with states like Utah, Colorado, Montana, how they do it in their contracts. So we were prepared to award a contract this past year. With the budget reductions and the necessary cuts, I didn't feel it was appropriate to all the applicants at that time because we announced that later. So we're going to RFP in January, as I said earlier, 21. We are going to also include a separate proposal to submit for pharmaceutical. Our pharmaceutical, as you see in the report, is $1.7 million, and the one substance is less than 200,000, so we can't be competitive. But one thing that we can do, as we look at it, we're going to provide ourselves options to have a provider as well as maybe a different pharmaceutical provider. Now, what we've learned, and I'll go into our hepatitis next, our hepatitis C treatments. What we have learned, though, is dealing with a larger provider that actually our hepatitis C medications are much cheaper, much more than Medicaid. So, Madam Chair, before I begin with hepatitis C, I'll stand for questions from you or the committee.
Questions for Mr. Shannon? Okay, I will put in, and certainly Department of Health always does super studies, but one of the things that we had, Senator Scott and I had intended based on our Louisiana visit last year, and we talked with a legislator from, I think it was South Dakota, might have been North Dakota, but one of the Dakotas, about the possibility of not just trying to buy for Wyoming, which is certainly a very small population, but maybe being able to group with, say, 5 other local states. You know, I mean, if you add up the populations of Idaho, Montana, the Dakotas, you know, I mean, it would be a bigger population. So that was something that may not have really been assessed. And of course, with the transition at Department of Corrections, that may not have been something that, you know, you had time to consider or think about. But just so going forward, certainly Senator Scott and I are willing to go to bat, as it were, or, you know, if there's something that needs to be done to make, to clarify authority for you to somehow work out. We know that there is the Sovereign States Group for the Medicaid purchasing, but if you thought that there would be advantage to you in grouping together with other departments of corrections in other rural states nearby, we are very open to helping you do that if it looks like it would be advantageous. Because certainly the person from the Dakotas was enthusiastic about that thought.
Madam Chair, committee,
Director.
I am familiar with the directors from the individual states that you spoke of, and we have bi-weekly conversations, mostly speaking of COVID and things of that nature. But I'll assure the committee that I will start that discussion and report back to you.
There may be something there. Senator Scott looks like he's got his hand up.
Madam Chairman, and I would add to that what we heard was that there were currently 3 drug makers that had effective hepatitis C drugs, and that if you had enough volume, they would bid against each other competitively. And there was the opportunity for major savings. And it's something that is not, you know, we can't avoid having to use them because we'll get sued if we don't treat some of the people that need it. So it's not an expense we can avoid, but that if you could get enough volume put together, there was the opportunity for getting the drugs much cheaper. But since our volume is so low here in Wyoming, we would have to go outside, and there would be advantages to doing it jointly with Medicaid and with the state employees group, possibly trying to build our own volume. But the key to it seems to be getting the volume up. So I would certainly encourage Corrections Department to look into that, because it looks like it could be a major cost driver.
Okay, any more questions for Director Shannon? Okay, let's see, what's the next topic? I almost made you leave.
Madam Chair, the
More coffee.
next topic is just a update and a follow through with Co-Chairman Scott. It's the update on hepatitis C and where we stand at this point. As you're aware, initially we thought our cost would be in excess of $4 million. And our legislators, we adopted the Bureau of Prisons policy to treat, there's 3 classifications in hepatitis C, but to treat levels 1 and 2. And with Co-Chairman Scott's comment regarding litigious inmates, especially when state of Colorado pushed forward and said they're going to treat everyone, we have since taken that pathway. And I may report to the committee, there are presently 31 Category 2 cases within our facility and 53 Category 3 cases. There are 20 cases presently undergoing treatment, on all but 2 were Category 2s, and the remaining are Category 3s, if that makes sense. We were authorized by legislation to transfer any remaining funds up to an amount of $975,000, which we did. Our department did do a B11 and transfer to fund, and I'm very comfortable that that's going to complete our treatments to get it updated. In our new contract, it will clearly indicate the treatment of number 3s. So that should block off most of the litigious approaches that we may have. I may report, and I'm not sure if it's a trade secret, but it's not going to be in a little bit here, that we can purchase our, we're on to Chairman Scott's comment about the multitude, the more people we can get dealing with a larger provider, a service provider for medical. We're presently paying $19,500 per treatment. That is much lower, in my understanding, than we are paying, than most others are paying, because they're purchasing in bulk throughout multiple states. The new contract that will be proposed, the medical contract, the RFP will include, as I mentioned earlier, Madam Chair, it will include treatment for all new inmates entering our facility. I'll stand for questions of the committee.
Great. Questions for Dr. Shannon? I don't see any. Go ahead.
Madam Chair, committee, I'll just do a brief updating. I listened to the presentations yesterday, and it was very enlightening to see, even from different perspectives and viewpoints, how we want to correct and how we're going to respond to our mental health. I would first start out, your Vice Chair, Senator Baldwin, forwarded a request to you, and this was by, the comment was by Mr. Craig. Would he participate? Because he is a subcontractor to the Department of Corrections. And absolutely, I just want to assure the committee that as we have further discussions regarding mental health issues, that Mr. Craig will not be held by the Department of Corrections in this legislative session to push any bills through. I can report out that our chronic care list, effective 9/14, reveals we currently have 468 inmates who are receiving mental health treatment services. So it's roughly 20% of our population. Of these 453 are currently on psychotropic medication. So it's 97% of our clients. Now that'll tie in with our pharmaceutical bill. 83%, which would be, and I don't want to be confusing or throw too much data out, which would be 390 of our mental health clients, they have a history of substance abuse. And I just want to say, I was thinking back about the bills that were presented yesterday, or the drafts that were voted upon. The Department of Corrections stance of that, we as the recipient of trying to assist folks in getting our citizens back in the community, which is our number 1 priority, safely. We definitely have issues that were all brought up yesterday. I clearly understand that Senator Bouchard made a comment about having a history in the background and working in corrections, and it does take a special person. And I do recognize that if you have that background, how much different it is and how you're able to assist. But it would be the department's stand that we want to make sure that we provide treatment services that are equivalent to those in the community, which I think we all want. We suffer from staffing. The qualified experience is very much what you're talking about with the therapists and the Department of Authorizing Licensing. We have difficulty continuing to fill therapist positions. Madam Chair and committee, we were also impacted by COVID-19 on the restrictions. That had a huge impact on our mental health community. Our treatment services were provided. I mean, presently we're allowed up to 10 individuals now, but for several months, I would say April through end of July, we were only doing individual treatment because of the COVID-19 pandemic. This has lightened a little bit where we can have group participation up to 10. As I mentioned earlier on the number of, which was 83%, it's co-occurring with mental health and substance use disorder, those inmates. We're working with Gateway, Corizon, Mrs. From WAMSAC, I'm sorry, Andy. She's always available to us and participating in how are we addressing this information. And lastly was Mr. Springer's discussion yesterday on trying to get information, and the committee was right on, at least from my perspective, was right on track with how are we going to present and offer medical information electronically, and how can we get it out to serve our individuals once they're back in the community. House Bill 30, and I'm not going to get down any rabbit holes, just the education part of it, and the House Bill 31 that's progressing, it's moving forward, as I said last time in our July meeting, and it's also helpful and it ties in with mental health. So, Madam Chair, that's my brief report. Our troubles are very much what has been mentioned yesterday that I think a lot of committee members are dealing with. How do we get folks licensed appropriately? How do we provide medication effectively and within our best diligence of our funding? And lastly, how can we get the information out electronically so we can all work together and not do dual work? Madam Chair, I stand for any questions regarding our mental health issues within our correctional system.
Questions for Director Shannon? Representative Sweeney.
Thank you, Madam Chairman. Thank you, Director Shannon, for that great report. In listening in yesterday, I think Madam Chairman Wilson's two bills, I think will be helpful, in moving forward, with the corrections community. Sorry about that. And so I'm wondering, in the scheme of things, if over time, if you develop any ideas on how we could better assist the Department of Corrections, with licensing and all of that, because it is a specialized, I believe, within the prisons. Is there a better way to do that? And we don't need that discussion right now, but I just would throw that out as an offer as far as one committee member. Is there a better way that we should look at this? So, and down the line, we can have that conversation offline, obviously, but I just throw that offer out there as far as I'm concerned. So I appreciate your willingness to look at different avenues to save the state money and get more providers into the state. And I think we made some progress yesterday, thanks to Co-Chairman Wilson's efforts. So thank you.
More questions for Director Shannon on the mental health and substance abuse side. Senator Schuler.
Thank you, Madam Chair. You mentioned that staffing and licensing is maybe going a little bit better. And maybe that's, and obviously with the COVID, being able to do group activities, I think is probably helpful. But I guess I'm asking, some of the county jails were able to take some of the folks from Rollins, and then and I think it was because of lack of staffing. So I guess what I'm asking is, are the staffing issues, are they being improved somewhat so that we can get some of these folks out of the county jails and back into Rollins? And does that help a little bit with money, with budgeting and that sort of thing? Thank you.
Director Shannon.
Madam Chair, Senator Schuler, I may report the following to you. We had our individuals in Mississippi, and because of COVID, we had a delay. We returned all our inmates beginning in July, returned from Mississippi. We had our ladies housed at Scottsbluff. There was 34 individuals. I had those returned prior to Labor Day. We removed our inmates from the counties of Niobrara and Goshen, and we currently have contracts And we have approximately, in this anecdotally, I think 17 inmates in Lincoln and Uinta County that will be returned back to our facilities by the end of the month. We still struggle with staffing at our Rollins facility. It's safely run, but my next approach is how we're going to deal with overtime. So I may report that the housing from you mentioned, Madam, I believe you questioned, are we saving cost? Approximate cost return from the county jails, Mississippi and Scotts Bluff is just a little under $700,000 a month we're saving.
More questions on this topic of mental health? Okay, Director Shannon, then you'll tell us about your cuts, I guess, is next up.
Yes, Madam Chair, if I may, to Representative Sweeney, I appreciate the offer for support for licensing, and thank you. And also, I failed to report, Madam Chair, that we did apply through the CARES Act for the $198,000 for telehealth adoptions. Department of Corrections, we own it. We drug it on our feet a little bit, but I feel confident that it'll be purchased and put in place prior to the end of December 31st, which is required.
Great.
Moving on, Madam Chair and Committee, I would just report briefly on our budget. As you're well aware, there was a 3-tier system. Tier 1 was with the reduction of contracts and filling positions. Tier 2, which the Department of Corrections has completed. At that time, our budget went, we returned $21,366,000. I'm meeting with the budget office today to address Tier 3. And what does that 21 million look like? And I'll just give you a brief update. The Department of Corrections lost 165 positions in this Tier 2. And in fairness, and so there's a clear disclosure, 82 of those positions were vacant and unfunded. So that really has no bearing on our budget. 69 of those positions were funded and vacant. And I had the misfortune, we terminated employment for 14 employees, 9 from central office and 1 from each institution. What does really the 82 look like? And Madam Chair, we eliminated and combined our religious contracts, our AWAC positions. We are providing services to each facility, but the example is we combined our Wyoming Honor Farm in Riverton with our state penitentiary. We reduced the hours of religious services for our Native Americans. We removed funding from 4 AWAC positions, at-will positions they were support staffs for our field services. And I'll just go down a few lists and give you some idea what things look like. We put the reliance on production and productivity. And some of the examples, our commissary manager, that position is relied now through and is funded through our funding that's dealt with our inmate commissaries, meaning if you're self-funded or we're not going to have the position.
And Mr. Shannon, let me just interrupt you for a moment. So committee, I don't want to break up Mr. Shannon's presentation because he's probably got it all lined up. But remember, the Department of Corrections does have judiciary as a home committee. So, and I was going to say later, but in the past, we've not really had Department of Corrections coming to Labor Committee much. Then a couple of years ago, when we started looking over Title 25, I think there was a little bit more involvement. I do think, Mr. Shannon, that we will very much welcome and hope to hear from you on the medical and mental health issues of the inmates, because that certainly is in our interest. But so committee, just as you ask questions of Mr. Shannon, really we will focus on the mental health and substance abuse impacts of any funding cuts. As I say, Mr. Shannon, go ahead with your list because you've got the list kind of set up, I'm sure. But because I know it's all a holistic thing, but as a committee, we don't need to, I don't think, inquire much as we might want to know about some of the things that don't fall under our wheelhouse. Go ahead, Mr. Shannon.
Madam Chair, Committee, I would like to readjust my presentation. I would like to readjust my presentation.
I wasn't told you had to do that.
No, Madam Chair, I believe, it was my belief that you wanted a detailed report. I can report out that there was under the tier 2 level, and I am receiving a lot of support from the governor's office on this, that substance abuse, mental health was not cut. We did make cuts, $2.2 million to our ACCs, which does affect our communities. And how that takes place, it's a reduction from Gillette, Casper, and Cheyenne ACCs that we can now only pay for, I believe it's 67 beds per facility. So that does have some effect on how the courts and the judicial system works to put probationary individual in there. So I may report to the committee that we have not had cuts, and we are getting strong support. Doesn't mean it won't happen in tier 3 though. I mean, we'll adjust to whatever we need to do to get us through this difficulty. We do not have any cuts, Madam Chair, regarding mental health or substance abuse at this time. I'll just sum up the presentation then. How did we look 10 years ago? Thinking back of cost 10 years ago and where we came from. Was the Department of Corrections funded adequately? We were funded more than adequately 10 years ago. That's why the department always had reversions. Our population increased 11.8% in the past 10 years since 2011-12. Our reduction in staff is 229 positions. We've lost 229 positions since we've opened Torrington, WMCI, and our budget is now $42,031,000 less. Are we getting close to the tipping point? I'm evaluating that every day, Madam Chairman. I'll stand for questions.
Chairman Scott.
Madam Chairman, just one quick question. You mentioned ACCs. What does that acronym stand for?
Mr. Shannon.
Madam Chair, Co-Chairman Scott, I apologize. It's Adult Community Correction Centers. We have contracts with 3 boards, one located in Gillette, one located in Casper, and one in Cheyenne. And they'll house our inmates that are released in community centers, and then as well as the courts and the local judicial prosecutors will utilize them for sentencing as an alternative thing to prison.
Representative Sweeney.
Does adolescent, thank you, Madam Chairman, does adolescent behavioral and incarceration fall under your wheelhouse as far as any contracts with, say, WBI through the state hospital if they've been incarcerated?
Director.
Madam Chair, Representative Sweeney, the Department of Correction does not have authority over any form of juvenile retention. We do receive juveniles if they're certified, not dependent children, but we do if they're certified through the courts as an adult. And we often have 1 or 2 a year, but we have no contractual agreements with any form of juvenile detention.
Thank you.
So, Director, I also serve on the Governor's Behavioral Health Advisory Council, and my understanding from the last meeting was that Sam Borbely, I think is his name, who was the head of the mental health and substance abuse unit in some way, what has been riffed. So is that how is that position going to be? Whatever work, I presume he did work. What work is how is that going to be filled in, or how did that play out?
Madam Chair, committee members, I didn't want to get in directly with an individual's name, but yes, there was a number of positions, and I'll discuss them. Our public information officer, we've lost probation paroles, unit managers, things of that nature. In reference to our programming, Mr. Borbet did a tremendous amount of work. That is being divided up between deputy administrators, and we're going to do the best we can to produce the work. I know there was a question, there was concern with public information officer. We have a system in place, but it's really not what the public was used to. The question was raised by Co-Chairman Scott. Are we providing the services? Absolutely. I believe we're more transparent, working harder now than we ever have, but the services are not coming to the extent that they were years ago. So will we keep up with, to answer your question, or to finalize your question, will we keep up with Mr. Borbolet's work? Yes, but it'll be at a slower pace because we're doing the best we can.
Yeah. Well, certainly we would all like to have all the people and all the money and as few clients as possible, but that's not really the world, is it? Any more questions for Director Shannon? I don't see any more. Well, thank you very much. And again, as I say, in past years, there's not been as much participation by Department of Corrections, and certainly we're not planning to take you away from your homeland in judiciary, but because we've got citizens in there, and I think it costs the state a lot of money in addition to the impact on human lives. We will certainly invite you in, and if you ever feel that you need to present something to us, you are always free to request to show up. We will never turn you away.
Madam Chair, Committee, Department of Corrections appreciates the support, and I would be gratefully enjoy being called upon.
Great, thanks very much.
Madam Chair, may I be excused to attend other duties?
You certainly may be excused.
Okay, thank you, Committee.
Okay, Elizabeth, I believe we're up to DFS, and let's see.
Ma'am.
I'm just going to tell the committee. So committee, at around about 10:30, we also have a specific time so that we can hear from a Canadian pharmaceutical person. Elizabeth, I leave that to your discretion on exactly how we should, was there some flexibility in that time, or DFS may be able to tell us in 20 minutes. I don't know. How long do they think they need?
I am uncertain as to how long DFS may need, but now is a natural break if we would like to take her testimony instead of interrupting DFS. But again, ma'am, that's to your discretion.
Okay, let's do that. So committee, you know that we have the the final report on the prescription drug importation study. It was originally scheduled for yesterday afternoon. We do have one person testifying from Canada, and I don't really want to leave the lady having to hang around for ages. So I know that because we've heard the initial study on this, and hopefully you reviewed it, you can plug in what she says into the study as it's reported later, but we'll go ahead and take her testimony now, just for convenience of everybody.
Ma'am, I will go ahead and admit Ms. Adams now.
Okay. Ms. Adams, welcome.
Thank you very much for having me, and thank you very much for accommodating my timing request. I really do appreciate it.
Well, sorry to drag you over from yesterday, although I guess you weren't actually in town anyway, so it wasn't quite as bad as having driven down from Toronto or something, but.
Certainly, yes, it was certainly an easier place to wait. So I'll present.
Just introduce yourself and then go ahead and give us what you want to say.
Yeah, so I'm Christina Adams. I'm the Chief Pharmacy Officer for the Canadian Society of Hospital Pharmacists, and CSHP is a nonprofit that represents pharmacy professionals working in hospitals to improve patient care by safe and effective medication use. I'm also a practicing pharmacist. So I'd like to thank your own Department of Health for the economic study they released last week. In it, they concluded that drug importation would not lead to sustained savings for your state. Our nation of 38 million people does not have the pharmaceutical supply for America's 329 million citizens. And Wyoming is not the only state considering Canada as a pharmaceutical source. If US states import our drugs on any kind of scale, price differences between our countries are likely to disappear. As an organization of pharmacists, CSHP is sympathetic to the challenges that Wyoming's patients face in accessing affordable medicines. But importation is such a poor solution that we have joined the Alliance for Safe Online Pharmacies Canada to advocate for a ban on medication exports for US programs like these. Importation will also exacerbate drug shortages that already harm Canadian patients. Canadian pharmacists already manage as many as 2,000 drug shortages at any given time, and in a recent survey, 1 in 4 Canadians reported being affected by drug shortages. In hospital settings, these shortages directly and negatively affect patient outcomes. Instead of doing clinical work with patients, pharmacists spend too much time sourcing scarce drugs, finding appropriate substitutes, repackaging for correct dosages, and communicating with other healthcare professionals about these shortages. Wholesale drug importation will hurt Canadians, and as the Department of Health's admirably thorough research shows, it will not help Wyoming residents with drug prices. We hope Wyoming is able to pursue other avenues to make medicines more affordable. And I'd be happy to answer any questions you might have.
Thank you very much. Questions for Ms. Adams? Representative Barlow.
Thank you, Madam Chairman. So if I could, ma'am, would you just describe in the briefest terms how Canada sources the majority of its pharmacological prescription pharmacology? Thank you.
Absolutely. So about 2/3 of the medications that are distributed or dispensed in Canada come from foreign sources. So this could be the United States. It can be other foreign countries such as potentially India or places in Europe, China, that sort of thing. So the vast majority of our medications are imported from external sources outside the country.
Follow, Representative Barlow.
Thank you, Madam Chairman. And to be clear, who is the purchaser? Is it the government system that purchases that 2/3 and the remaining 1/3, or is it individual pharmacists and healthcare providers? Thank you, Madam Chairman.
Ms. Adams.
Yes, so medications that are brought into Canada go to distributors. You're usually purchased by distributors or the manufacturers themselves will, some of them have head offices in Canada, and so they'll import directly from their other sources outside of Canada to their warehouses. And we have a distribution system in Canada for getting medications to retail community pharmacies and to hospitals. The only time that the federal government purchases medications directly is for our national emergency stockpile. There is a certain number of medications they will carry there, and as well as for, excuse me, and that's basically it. And usually it's done again through the distribution system in Canada.
Chairman Scott.
Yes, thank you, Madam Chairman. Am I right in thinking that the prices that are paid for the drugs are set? Are they paid by the individual patient that uses them? And am I right in thinking that the prices are set at the provincial level?
So, thank you. For medications that are covered by the provincial governments, so this would be, for example, for senior citizens, for people on social assistance or on disability, the prices that the government will reimburse the medication at the pharmacy level are set by each individual provincial government. When it comes to patients who have private insurance or who are paying out of pocket, there are prices that are set for brand name drugs. We have the Patent and Medicines Pricing Review Board that sort of sets the standard for certain patented medications. So this would be brand name medications. And when it comes to generic medications, more often than not, what a private insurer will reimburse will be very similar to the pricing points that the provincial governments will set in their reimbursement models.
More questions for Ms. Adams? Ms. Adams, I do have one question. As we were investigating early on, and of course the whole COVID thing has brought up a lot of discussion, I'm sure there as well, about supply chain issues. And so as I talked to some of the pharmaceutical reps, I heard the discussion about how the drugs that the US folks were planning to import have FDA oversight on the ground in China or India or wherever. Does the Canadian government do anything similar as far as oversight of what the distributors might be importing, or is that left up to the manufacturer locally?
So that's a great question, and thank you. The distributors can only import medications that are approved for sale by Health Canada. So they have a drug identification number, a notice of compliance in a very similar fashion as the FDA oversees approval of medications in the United States. Health Canada does inspect and certify manufacturing facilities outside of Canadian soil. And so they do hold those manufacturing facilities to the standards that they set, which are GMP and others, to ensure that the medications that are produced in those facilities meet Canadian standards.
Super, good to know. Okay, any more questions for Ms. Adams? Well, we wish you all the best.
Thank you so much for having me today. I appreciate
Thanks
the
very much for
opportunity.
participating.
Thank you.
Okay, very good. You're welcome to hang around if you're curious. But
Certainly.
probably you have work to do.
Thank you.
Okay, Elizabeth, let's fire up DFS.
Yes, ma'am. I will let Director Schmidt in now.
Okay. Okay, Director Schmidt. And Elizabeth, just remind me, do we have a report in the big committee materials from this, or, and do you know what page it is on if we have it?
You do have it, ma'am. I do not have that page number immediately, but I'll look it up.
That would be helpful. Director Schmidt, good morning.
Good morning, Madam Chairman, members of the committee.
I think you, there seems to be a lag. Is everyone else seeing Director Schmidt's voice with no lips moving, or have you taken up ventriloquism in your spare time?
Madam Chairman, can you hear me okay?
There, that seems to be, I'm not sure what happened, but yes, I can hear you all right.
Okay, thank you. I'm having a bit of delay through the internet today, so if worse comes to worse, I'll switch to my laptop.
Okay, I think we're all right now.
Well, good morning. My name is Corinne Schmidt, and I'm the Director of the Department of Family Services. I was asked to speak today on two issues. One is the Step 2 reductions, and the other is information on maintenance of effort and match requirements for federal grants. We provided two handouts. One is in regard to the Step 2 reductions that outlines the reductions that we've taken. And then the other gives you a little bit more information around our federal grants and the match and maintenance of efforts requirements. I know that you have a packed agenda, so I'll go through this relatively quickly. Based on the conversation with Interim Director Shannon, I think you wanted to focus more on mental health and substance abuse reductions. The document that we provided you gives you an overview of all of our reductions, but to focus in specifically on mental health and substance abuse, I can go that route if you prefer.
Actually, Director Schmidt, seeing as we are your home committee, we will be glad to hear them all. It was just that Director Shannon, many components of the Department of Corrections are not really falling under our eagle eye, but I think that we would like to hear about all of yours.
Okay, well then I will start at the top. So if you all have the DFS Step 2 reductions. First, we followed the guidelines given by the governor regarding programmatic reductions rather than just across the board reductions, so the percentage reduction. So you'll see that appear in our Step 2.
Oh, and Director Schmidt, I'm going to interrupt you one more time. I apologize. So committee members, I did find in the very large packet, it starts on page 183 of our big packet. So if you want to set yourself up a split screen or, the 2 documents up, or if you just actually used up all of your printer cartridge and printed the whole thing out, I can't help you there necessarily, but if you've got it up on the screen, page 183. Okay. Now, Director Schmidt, I'll attempt to be quiet for a little while.
Okay, thank you, Madam Chairman. We also identified funding that was considered unrestricted, which means that it's not already identified for match or MOE. That was another filtering process we went through. We looked for opportunities to leverage federal funds. Our budget overall is about 50%, a little less now after Step 2, State General Fund. The remainder is federal fund and other fund. So what we're really looking at is not a lot of State General Fund available for unrestricted access. So to start with our overview, from an administrative and position standpoint, we eliminated 18 positions, 7 in our Economic Security Division, 6 in our Social Services Division, 2 at the Wyoming Boys School, and 3 at the Wyoming Girls School. And then we made administrative reductions throughout each of the budgets in regard to travel, office supplies, training, human resources, etc. Programmatic reductions that we made, the 2 programs that we reduced were not being used for match or MOE. The first one was the burial program. And this is a program that was available for families whose loved ones were on TANF or SSI or Medicaid and passed away. The family could apply for assistance with burial expenses. We eliminated that program out of our standard budget. However, there was one-time funding given to us in the 2020 session. We kept that so the program will last as long as those funds last. And that was about $123,000. We also eliminated the community juvenile service boards, the funding for the community juvenile service boards. The boards will stay intact. It's just the funding coming to the department that will decrease. That program will end June 30th of 2021. So we gave a 1-year contract, eliminated the rest of the money, and then in the next biennium, the full amount will be reduced. The community juvenile services boards pay for community juvenile diversion programming. They exist in about 14 communities. About half of those use their funds to pay for some sort of mental health or substance abuse service, whether it's family counseling, mental health assessments, the juvenile and family drug courts, crisis services, tobacco cessation, and other substance abuse prevention. There was a required match by local communities. So the program, the State General Fund wasn't funding 100% of the program, but it was providing a good portion in most communities. In terms of service reductions and impacts, we reduced approximately $2.7 million in our local services budget for services provided to children and families, primarily children who've come into care. About $2 million of that was general fund. We are taking a global reduction with those dollars. We did not reduce rates. We did not pull any of those mechanisms. We'll just monitor our budget very closely and make funding adjustments as we need to manage within that 2.7. We spend about $20 million over any given year, so 40 million a biennium. So we should be able to adjust spending in order to accommodate that $2.7 million reduction. It's in this budget. This is again our local service budget, which pays for services to children and families, primarily costs associated with children being placed outside of their home. We did a state general fund reduction of about $6.4 million, but we've replaced it with TANF federal funding. So TANF is our Temporary Assistance to Needy Families grant. Those dollars are eligible for families if they meet criteria. If the family and the child and the services meet the TANF criteria, then we can use TANF funds to pay for that service. You also saw a small reduction in our child support direct services contracts. The child support program is administered by the state, but the actual services, attorney services, case management are provided through third-party contractors in every community. So those contracts were reduced by about $260,000. So that is, Madam Chairman, a quick summary of our budget reductions. In the handout on page 3 is a high-level summary if there's any questions.
Questions for Director Schmidt? Director Schmidt, I just have one, really, it's sort of a smallish issue, but I've heard from, so on the burial program, I had understood, and maybe there's 2 different programs, I had understood that we had a program that provided payments to the funeral homes. Is that a separate program from this? Because I know that there was also, just could clarify that for me, if you would.
Madam Chairman, that is the same program. It's the families apply for the benefit, but then the payment is made to the funeral homes.
So I guess I was kind of visualizing, the old medieval potter's field or something where you've got homeless people who have no family members at all, and the funeral homes would bury them. How do those type of individuals fit into this? Or aren't there any, really?
Madam Chairman, this program pays for family members who died who were in one of the programs that I mentioned. Indigent burial, I believe, is covered by the counties. So if there's someone who passes away and we're not participating in any of the benefit programs, had no family members that were known, then the county then covers the costs of the burial.
So wasn't there a program where state money went to the counties and that, I mean, because I think we've cut that also, or I don't know. Okay. I think I may have been merging 2 separate things in my head, and maybe people do merge them in their heads in general. If you find out more about that, let me know.
Madam Chairman, in 2016, we did reduce that part of the program. So this program has been through a series of budget reductions in 2016 as well.
Had you previously funneled some money from this budget to the counties for that?
Madam Chairman, yes, prior to 2016.
And so do you funnel any money to the counties now for this?
Madam Chairman, no, we do not.
Okay, so the attempt of the funeral directors to raise the death certificate costs to provide money was really for that other program or for both of these? I mean, where would that money have gone to if that had passed?
Madam Chairman, I don't remember the specifics of the legislation, but the general intent was to create a funding source for indigent burials because those dollars were decreased or eliminated for counties. So it would be one potential revenue source to pay for those costs.
But it really could go for both places. I mean, aside from whatever the legislation said. So there are really these 2 separate programs in a way. Okay. Just to clarify that in my head. All right, Okay. Oh, Senator Schuler.
Thank you, Madam Chair. Yeah, Director Schmidt, I just wondered about the, when you talked about the TANF block grant, the fact that you're going to use that to reduce the impacts to the kids, and you're going to look at changes to TANF eligibility tracking. Could you talk about that just a little bit and maybe emphasize what those are?
Director Schmidt.
Madam Chairman, Senator Schuler. So the TANF funding that we're using was always allocated for the purposes of social services. However, because we weren't able to identify enough children and families that were eligible, we weren't able to use the federal funds. With a review of our policies and practices within social services and a review of our case management system, we were able to implement changes to that system that will identify more families who are financially and programmatically eligible. So in a nutshell, we're doing a better job of hunting them down and identifying those service dollars that could be TANF reimbursed.
Thank you.
Okay. All right. Very good. Director Schmidt, carry on.
Okay, Madam Chairman, I have some basic information on federal requirements for match and MOE, but essentially to define what match and MOE are. So MOE is really called maintenance of effort. And in a lot of federal funding streams, not just ours, but in numerous federal funding streams, the state has to show that it is participating or doing its share to contribute to the program. So it's basically the state's skin in the game. So in response to receiving federal dollars, we have to demonstrate that the state is also spending money on similar services. So that's maintenance of effort. Match is a little bit different in that you spend $1 to get $1 or whatever percentage that is. So we also have federal funding streams that are matched. So we pay a state general fund dollar and then we receive a reimbursement for whatever percentage the program allows. That's similar to Medicaid. We also have some match programs. So maintenance of effort is important in that we have a minimal amount we have to spend in order to continue to receive the federal dollars. If we don't meet that maintenance of effort, then there's at risk, sometimes penalties, sometimes reduction in the amount of federal fund available. So we have quite a few federal funding streams that come into the Department of Family Services, and that's in that document that is also included in your packet. I will not go through that document. It really is just for your background knowledge. But essentially, we have two major federal funding streams that require maintenance of effort. The first one is TANF, as I mentioned, Temporary Assistance to Needy Families. And every year we must spend $9.7 million on TANF eligible services to TANF eligible clients. So the 9.7 per year is our skin in the game. On the Child Care Development Block Grant, we have match and maintenance of efforts requirements. So our total general fund for both that we need to have in place is 4.7. Our maintenance of effort of that, our maintenance of effort is 1.55 million and our match is 3.25 million. But the bottom line is that we have to spend $4.7 million, the state general fund, on activities related to Child Care Development Block Grant services per year. Then our other two kind of major funding sources come through Title 4E, which is a reimbursement, that's more of a match, and then our child support, which is also a match. So for both of those programs, well, for the 4E specifically, it's an eligibility-based program. If the child is eligible, the child and family are eligible, and the service is eligible, then we can receive 50% of federal reimbursement for those services. Also under the 4E program, money spent on direct support, meaning our caseworkers, and money spent on training are reimbursed at a higher level. So services are reimbursed by the feds at 50%. Training and administrative casework services are funded at a higher percent, I think around 75 to 80%, depending. So the money that is spent on 4E is variable depending on if the child and family meet the criteria and then the services meet the criteria. So it's not a block grant, it's not a set amount of money, it's based on who we serve. Child support is another program where we have matched dollars. And the match for child support is about 66% federal, 34% state. So for every dollar we spend on child support activities, we get 64 cents back from the feds. And there is no limit on those dollars. We can spend as much state general fund as we want. The feds will match it on purposes related strictly to child care or child support. So as we look at reductions from step 2, we are monitoring our maintenance of effort and our match requirements very closely. After step 2, we are still able to meet all of our MOE requirements. Step 3, we're looking at every dollar very diligently to ensure that we can continue to meet our federal requirements in order to receive those federal funds. The federal funds mean a lot to us. As I mentioned before, a combination of federal and other funds make up about 50% of our budget. So we do need to keep track of those dollars carefully.
Questions for Director Schmidt? Senator Scott.
Back on the TANF issue where you're replacing the general fund money with TANF dollars. What were those TANF funds previously spent for?
Mr. Chairman, or Madam Chairman, sorry,
Yeah,
Co-Chairman Scott, those dollars have always been appropriated. They were just not being spent for that purpose. We are just now able to access them. So Madam Chairman, Senator Scott, if you look in our budget, you would see that those TANF dollars were appropriated for social services.
Okay, they were appropriated, but nobody I know there's been some TANF money spent elsewhere in the state government because it's a byproduct of the welfare reform. Is this those dollars or is this monies that we just weren't spending at all?
Okay.
Madam Chairman.
Yeah, if you could, Chairman Scott, you were garbled a little bit from your internet, but Director Schmidt, if you could make that out.
Madam Chairman, Senator Scott, I think you were asking if the dollars that we swapped are part of the annual allotment, or if they're unspent dollars from previous grant years. Is that the question?
No, the question is, were the dollars federal monies we weren't spending at all? So is it new federal money coming in? Or were those dollars that were being spent by other agencies? I know some of them were at one point spent for preschool programs. Some of them were spent for the nurse home visitation program in previous years. I don't know what's going on now.
Director Schmidt.
Madam Chairman, Senator Scott, there were dollars that were always appropriated for this purpose. We do have funds that have not been spent by other grantees. We're evaluating our whole TANF program in light of what dollars are getting spent and what dollars are not getting spent. So basically we allocate funds for certain purposes. Sometimes those funds get spent, sometimes they do not.
Is that a follow-up, Chairman?
Yeah, Madam Chairman, I'm still not certain. Are we going to hear from our constituents, gee, we were spending TANF dollars on X and it's no longer available, and we've had to discontinue this program or that program? Is that what's going to happen? Or is this new spending And if it's new spending, is it increasing our welfare?
Dr. Schmidt.
Madam Chairman, Senator Scott, yes, we will have to reevaluate our spending on our TANF funds in order to accommodate this allocation. We are developing a plan to look at reprioritizing those TANF dollars to understand better who's spending them, who is not, and to bring it in line with our annual block grant. So yes, we will start having discussions about what the reprioritization of our block grant will look like over the course of the next biennium or two.
Although if we have a maintenance of effort requirement, how does that fit with the reprioritization scheme?
Madam Chairman, so we receive approximately $18.5 million in TANF block grant funds every year. In order to receive those dollars, we have to spend an additional $9.7 million on general fund expenditures that meet the criteria. So we're spending federal dollars in addition to spending general fund dollars. If our general fund dollars get below that maintenance of effort requirement of 9.7, then we will start to look at decreasing annual block grant funds. The feds will decrease it in addition to requiring us to pay more state general fund to get out of the maintenance of effort hole that we've dug. But of the 18.5, we have a spending plan. So every year when we get those dollars, we have allocated to quite a few programs funding, TANF funding specifically for those purposes and those programs. That is the conversation we need to have, is how do we spend every year or in every biennium the $18.5 million we get yearly from the TANF federal program. Just a side note, out of those funds, out of the 18.5, approximately 3 million is for cash assistance. So I think that's the traditional program. We call it POWER, but that's the traditional program where families are eligible, or a person is eligible based on financial criteria. And about half of which then are also required to participate in a work program. At any given time, our caseload of cash assistance families is about 500. We're a little bit lower than that right now. And about half of those are typically eligible because they're taking care of children. So grandparents taking care of grandchildren make up about half of the cash assistance population. The other half are referred to and work with the Department of Workforce Services on work programming. The benefit as a whole is limited to 60 months. If a cash assistance recipient is still on the program at 60 months, their participation is terminated. So that's a little bit more than what you asked for, but I think it sets the context for how the grant is spent.
More questions for Director Schmidt. Representative Sweeney.
Thank you. Thank you, Madam Chairman. On the Child Care Development Block Grant, so is that where our Child Development Center schools are funded through, or is that Department of Education?
Director.
Madam Chairman, Representative Sweeney, the Child Care Development Block Grant that we received, the majority of those funds go to child care assistance payments. So eligible families who need child care assistance, we will pay the child care providers the assistance that is for the family that's eligible. So in some ways, the CDCs, the Child Care Development Centers, do get some of these funds, but not to provide the early intervention funds that I think you're speaking to. Those come through primarily the Department of Health and through the Department of Education.
Okay.
Okay, Chairman Schmidt. or up, sorry, you've been promoted. Chairman Scott.
Madam Chairman, on the TANF, what I'm taking away is, you see, these funds were a byproduct of the welfare reform, which was much more successful than anybody in Washington realized it was going to be. And they let us use some of the money that we would otherwise spend on cash assistance for programs that we chose, or the department chose, that would assist people on a means tested basis. That was the eligibility, and they're used widely elsewhere. So what this reduction is going to be is a bunch of those programs are going to get eliminated, and the members should be warned that you may well hear from some of them from in your district that had TANF money and no longer do, and they'll come complaining to us. We don't know which ones that'll be, but in the past have been a number of different topics. I'm surprised it's taken this long, but that's what's happened here, I think.
And Madam Chairman, if I may.
Director.
Madam Chairman, and to your statement, Senator Scott, we are not making any changes right now to any of those contracts and any of those funds. So you won't expect any fallout or feedback from constituents. Those funds are intact. We're just looking right now, starting the process of evaluating those so that we can better identify where money is not being spent, fill holes, etc. So that's not to say that the conversation may not eventually happen, but it will not happen during this year.
Director Schmidt, I do have one question. Looking at the programs, especially the ones where we have match requirements or maintenance of effort requirements. I remember from my time on appropriations that periodically the thought would occur to us that if we just got out of certain federal programs, then we wouldn't need to be tied to their requirements for match and maintenance of effort. And what we did hear on some programs was that they were required by federal law, whether we took federal money or not. So there would really be no, I mean, in other words, we couldn't escape by that route. So do you, looking at the programs on the list that might attract people's attention along that line, and if it's kind of a long list, you might just send it later. But any input on that sort of situation where, especially as legislators come into session, new legislators, they might say, well, if we just got rid of X, Y, and Z, where do we fall afoul of federal law anyway?
Madam Chairman, I don't have the whole list available to me of which ones could go away and which ones need to stay, but certainly the child support and the TANF grant that are intertwined in order, and this goes to Co-Chairman Scott's mention of welfare reform in 1996. As part of the major welfare reform, the federal government tied programs together, meaning, and this is the case too with Medicaid. So for example, Medicaid clients must comply with child support. They must engage with child support, with the idea being that those are dollars that can be made available or reimburse the government for expenses through Medicaid. The same thing is true with the TANF block grant. Those two programs are interconnected with participation. If you participate, to be eligible for one, you have to participate in the other. So when you start to look at them, in a couple, it may be an all or nothing where there'd be a substantial reduction in federal funds. which then becomes a major policy decision about do we want to continue those types of services.
Chairman Scott. Yeah, you're muted still, Chairman Scott.
Madam Chairman, some of what you're talking about we'll find when we look in the child development centers and the health department budget. There's some requirements there the feds have passed, which apparently they have constitutional authority to do, and will be compelled, whether we accept their money or not, to meet some of those requirements. It's true in some of the special ed in the education budget as well. When we look at the foundation program, which of course this committee won't, but that's where you find the real federal compulsion that's beyond. You've got to do this in order to get that program that she's talking about.
Okay, any more questions for Director Schmidt? Director Schmidt, we hope certainly and anticipate that you will provide pretty much the same chart unless you want us to forward it on to appropriations. But, you know, obviously we want appropriations when they sharpen up their red pencils to be cognizant and not discover match requirements several years later, as I seem to recall happened a couple of years ago. I know you'll be on top of that.
Thank you, Madam Chairman.
Okay, thank you, Director Schmidt. You're certainly welcome to hang around if you're curious, but if you have something better to do, we release you.
Okay, thank you, and thank you to the members of the committee.
Okay, Elizabeth, I guess we've got the Department of Health now to tell us all that they know, which is a vast amount.
Ma'am, we will admit the Department of Health now.
Okay. I see Franz Fuchs. Well, I don't see him yet, but I see his name.
Good morning, Madam Chairman, members of the committee.
Is it you? Are they leaving the whole burden on you today, Franz?
Madam Chairman, I know Stefan should be getting back from the governor's office at 11, so I can tap dance until then, or I could actually, if it's okay, I can do the pharmaceutical brief, and by that end of that, he'll be here to talk about the budget cuts.
Yes. Why don't you start with the pharmaceutical one? We've that'll plug in nicely with Ms. Adams from Canada. Were you able to hear her part of her presentation?
Yes, Madam Chairman, I was.
Good. Well, she said very nice things about your paper. I don't know if you're planning on submitting it to some sort of journal or something like that, but obviously that was very thorough. So go ahead with your, let's see. I printed mine out, I think, but for the rest of us who didn't print theirs out, let's see, where was that?
And Madam Chairman, I do have a presentation. I'm happy to share the screen and go through it.
All right,
if that works.
Do it that way then. Thank you.
Okay. Good morning, Madam Chairman, Co-Chairman Scott, members of the Joint Labor, Health, and Social Services Committee. My name is Franz Fuchs. I'm a policy analyst with the Department of Health, and here to do the pharmaceutical importation and group purchasing study brief. I know we talked about this in a month or two ago. I did an interim report. Not much has changed from the overall conclusions. And the conclusions, they're a little, I guess, a little bit of a downer. We recommend against pursuing most of the policies that were proposed. So what I'm going to focus on in this presentation really is more some of the economic fundamentals. And we think the background section and sort of describing the fundamentals of the pharmaceutical industry and how drugs are purchased is probably the most valuable piece of this study, just because the evaluation of the alternative purchasing arrangements and the drug importation really hinges on that. And we sort of are a little more brief in those sections. So if it's okay, Madam Chairman, I'll go ahead and proceed with this.
Yep, go ahead.
Again, this is the summary, the executive summary. So if you have to leave in the next 30 seconds, this is kind of the takeaway slide. We were told to study 3 policy options, and we recommend against pursuing any of these options. For as far as drug importation goes, it does show potential savings on its face. But when you start scratching the surface of just how the consumers might be find cost savings, there's a lot of complications involved with that, and it's really impossible to guarantee that those, for example, Medicare members would see decreases in their cost sharing if we were actually to successfully import drugs. And then finally, as noted previously, we believe there's some economic fundamentals that make it really problematic in the long term as far as sustainability goes. With respect to group purchasing, now we took this to mean looking at inside the state of Wyoming and kind of looking at across Medicaid and across non-Medicaid Department of Health and Department of Corrections. And the real, so Medicaid is obviously the elephant in the room when it comes to drug purchasing. It's not on its face $60 million program. Compared to the Department of Corrections, which is $1.7 million. So if Wyoming were to negotiate as a group, Medicaid would obviously you'd want to include that in the group. The real problem is that Medicaid has what's called a quote best price rebate, which is a statutory best price that Medicaid receives from manufacturers, and that legally really cannot be commingled with any other purchasing power. So it would not make sense to include Medicaid in any kind of group purchasing arrangement for practical and also legal reasons. And then when you, of course, exclude Medicaid, all those remaining payers are really too small to have any leverage. I think DOC would just be like any other large employer out there in the U.S. trying to negotiate on their own for savings. So I think the kind of ideas that you mentioned earlier and Co-Chairman Scott mentioned about group purchasing consortia with other states, I think there are economic principles and fundamentals in here that where that would make sense. But the problem with that is the devil's in the details. You have to be able to form that consortia, and that consortium has to negotiate and figure out what the rebate is before we could even start estimating any savings that might happen or might not happen. So I think that's certainly worth pursuing for the Department of Corrections, assuming they can sever their pharmacy business from their overall health services contract. But just because of the principles of aggregating those covered lives together makes a lot of sense. But again, the devil's in the details, and it's really hard to estimate what savings might happen because everything is really subject to negotiation. It's not just you're going to save 10% guaranteed. It's a negotiation that happens. And then finally, we looked at these bulk purchasing or subscription models. And the reason we recommend against this is because the states that are pursuing this, their real intent is not necessarily cost savings in the short run. It's really to eradicate Hep C. And so it makes sense when you're trying to eradicate the disease inside your state. You need as many as much of the drug as you can get. Generally speaking, these contracts, a lot of the details are proprietary and secret. So we're really not seeing, kind of what cost is being negotiated, but they seem to be kind of pegged at what the state was spending previously on Hep C. So they take that as like the starting point for negotiations, and then they, will take basically an all-you-can-eat type model of Hep C drugs with the goal of eradicating Hep C. And again, that's a noble goal, but I think it's not really and lowering drug prices. That's not really the short-term policy that's being pursued. And there are, of course, other complications with trying to eradicate Hep C, like out-of-state migration. I think it'd be relatively easy, given how people move around, to reintroduce Hep C once you've deemed it eradicated. And then, of course, the cost savings from that probably accrue to someone, but it may be Medicare that you're saving money for down the road if you eradicate Hep C. So again, there's just a lot of complications with that. And given that the focus of the study was on short-term savings, drug savings, we recommend against that for that reason. So with that, the real kind of meat of this presentation, we already talked about the Canadian drug import at the interim kind of update of this. So I'd like, if it's okay, Madam Chairman, to kind of focus on the economic fundamentals, and I think that's probably the most useful part of the study, as I mentioned.
Very good. If I can interrupt you just for a moment, Mr. Fuchs. So on my printout, I think there's you have a slide that says drug spending not much of a problem as overall healthcare spending. And I'm just you don't have to necessarily answer this right now. Maybe I'm kind of looking at this chart. My recollection from some Someone might need to mute. There's a lot of noise coming in from somebody. Some of the information from the multi-payer claims database showed that someone, it's not me, someone is making lots of noise. Everyone looks muted. Okay, the multi-payer claims database seemed to show that pharmacy spending in Wyoming was a lot higher than in Montana. That's not the whole nation, and that might not be, but if it comes up to where there's some place where you can plug in a thought on that, because I know you have spent some time with the multi-payer claims database. Just throw that in there if something comes up. Okay, go ahead, Mr. Fuchs.
Thank you, Madam Chairman. I hope the noise is not coming from me, but I unfortunately have to unmute myself to be able to give this presentation. Any rate, so the slide, just starting with the first slide, again, drug spending is sort of in the context of overall health spending. So as you noted, Madam Chairman, we did operate that multi-payer claims database for a while. We had that public site. That site is kind of a zombie site at this point. It's still sort of up there. It has some of the data we have, but we're not, of course, getting new data, and we don't have access to any of the raw data anymore because the contract ended in June. But it did show that costs overall for Wyoming were higher than Montana. This really looks just at national health expenditures. So CMS maintains this comprehensive data set of, it tries to tabulate all healthcare expenditures across various categories. And we're just comparing prescription drug expenditures, which are the orange bars, against national overall personal healthcare expenditures, which are the blue bars. And then out of pocket is the sort of brown bars at the very bottom. So I guess sort of the stacked bar graph, I think the takeaway is you see even after adjusted for inflation, these personal healthcare costs per capita, so adjusting for both inflation and population, are just going up and up. And you can see that since the 60s. And there's obviously various trends when it kind of starts flattening, like with managed care tend to flatten the curve a little bit. The recession flattened the curve a bit. But generally speaking, healthcare expenditures have been going up and up. When you look at the trend for prescription drugs, it's less. It's not necessarily it's not a problem. It's that it's less of a problem. And so you can see the flattening of those costs when you adjust for inflation after 2005. So for the past 10 years, 20 years or so, 10, 15 years, it's been relatively flat on an inflation-adjusted basis, though it has increased slightly. And so you look when you compare the total spending or the prescription drug spending to the total cost as a percent, it's gone down. It's sort of done this U shape where it's gone down from around 12%, dropped to a low point around 5% in the 80s, and it went up again, but has recently sort of been trending down. So I think that's sort of a function of prescription drugs back in the 60s through the 80s were a lot less effective at treating a lot of diseases. There's been a lot of research, obviously a lot of expenditures since then in developing very valuable and very cost-effective prescription drugs when you consider the value of the drug in the context of the overall medical expenses it sort of replaces. I think the other interesting takeaway here is looking at the out-of-pocket expense. And I think what's fascinating is when you look in the 60s, prescription drugs are almost considered a consumer good. I mean, it's 100% of the spending on it was out of pocket. So going to the drugstore, it was really on you to buy whatever drugs you needed. And I think the shift since the 60s has really been treating it more as an insurance product. So now very little, about 15% of drug costs are out of pocket. And particularly since the out of pocket costs you'll see in 2005, it's a little bit small on this graph, but they sort of peaked in 2005. So out-of-pocket drug expenditures on an average sense have actually gone down since 2005. And the most likely cause of that is the introduction of Medicare Part D, which of course paid for a large fraction of Medicare drug expenses. So just some basic sort of lay of the land as far as cost goes with prescription drugs. Then we start sort of getting into sort of the nitty gritty of the actual industry. And just some real high points here on the economic side. So I think one point here is that the fixed costs of drug development, regulatory compliance, and then of course marketing and overhead are huge components of the average price of any prescription. So that average price really, it's not so much the ingredients or the value chain and packaging those ingredients. It's really those fixed costs that any company incurs in just doing the research. And I think there were some pretty eye-popping statistics, like that it costs almost $1 billion per new drug, developed in terms of research and development. Those costs have to be obviously be recouped in some way, particularly when the vast majority of drugs in the preclinical stage fail. So, I think only approximately 5% actually sort of make it out of that stage. So you have to really cross-subsidize all those failures with any successful drug. And here you can see these graphs kind of show the average percent for those various categories. We took this off publicly available 10K data from publicly traded pharma companies. So I think there's 6 that were included in this sample. And you can see that, again, research around 30%, overhead around 30%. So about 2/3 of those costs are really fixed at that point. Next point to note is that manufacturers do see very high profit margins. So both the cost structure and the profit margin questions were specifically asked as part of the study. You can see the profit margins have averaged, around 15 to 20% over the past 5 years. And again, this is looking at those 6 publicly traded companies that are in the U.S. And you really see it here. I think the University of California has a report that did a very interesting sort of breakdown of the value chain. So when you're looking at how, when the drug is first produced, the variable cost of the drug itself is only $17 to the manufacturer, but they incur, of course, a lot of those other costs. So those are those fixed costs for research and development, regulatory compliance, and then you see there are very large profits, $15. So the manufacturer produces the drug on a marginal basis for $17 and sells it for $58. The wholesaler buys it for $58. Wholesalers generally have very, very thin profit margins. They are exceptionally efficient. In all this literature we did reviewing this, no one was complaining about the role of wholesalers in this whole pipeline. There's only, despite only being there's maybe 3 wholesalers that really control around 95% of all the drug distribution. But their profit margins are very, very thin, about 30 cents. And so the wholesalers will sell it to the pharmacy for 60. The pharmacy buys it for 60. They have a lot of fixed costs, running a pharmacy. If you have especially small volume, you're incurring a lot of fixed costs on employing your pharmacists and maintaining your licensure and all that other things. They make a modest profit, $3. They sell the prescription for 76. The pharmacy benefit manager, and so on and so forth. So I'm not going to just finish the rest of the table here, but at the end of the day, this basically kind of breaks down how a total $100 cost to the health or the individual, as it were, breaks down across this value chain. And I think the salient points are that you have a large amount of fixed costs for the manufacturers, but also a lot of profit.
Madam Chairman.
Chairman Scott. You're muted, Chairman Scott.
Franz, backing up to your previous slide, the marketing costs are in that overhead percentage. Is that right?
Madam Chairman, Mr. Co-Chair, that is correct. And we note that the role of direct-to-consumer marketing in this study. I think the U.S. is alone, along with New Zealand, in allowing direct-to-consumer marketing of pharmaceutical products.
Okay, go ahead, Franz.
So, Madam Chairman, continuing on to next slide. This shows kind of the complexity of how the payments work, and I think what's interesting is the actual product flow. So we're looking at the product flow in the black lines here. It's pretty much what you'd expect, right? You have the manufacturer produces the drug, goes to the wholesaler, goes to the retail pharmacy, goes to consumer. With this nuance here that there's sort of this valve diagram. The valve is controlled by a physician. So prescription drugs are not a normal consumer good. A physician does have to write a prescription for them. So they sort of control that. There's also some control over that in the or utilization management tools that an insurer or their PBM will impose. So for example, they can require step therapy, they can require prior authorization. There's numerous tools they can impose, including a really strict formulary just not covering the drug that also controls that flow of drugs, of product to the consumer.
And Franz, I want the committee to just stop and consider that component there when we talk about this or any other attempts to rein in healthcare costs, because this is the area where the consumer will typically squawk including myself as one of those potential people, when there is a restriction here. You know, I myself have been subjected to various requirements for failing on certain medications before the insurer will cover other things. And so this is, you know, what the rude way of talking about this is rationing. But that is really one of the key methods of reducing expenditures on whether it's pharmaceuticals or other types of things that happen. And I didn't want to drill into Ms. Adams from Canada, but when she said that they've got, I think she said in her letter, something like 2,000 drug shortages. You know, that's how you control utilization and expenditure. And that's the thing that most of us as consumers don't want to hear about and don't want to be subjected to. Just remember that. Mr. Fuchs, Senator Scott's gonna add to my little pontification. Go ahead, Chairman Scott.
Madam Chairman, the other thing that goes on there is not just rationing, but you often have situations where one drug can be substituted for another with major savings because of big price differences. Blood pressure medications are a very common example because there's a big federal, NIH did a big study that showed the generic diuretic was the most effective and the cheapest of the drugs. So some of what's going on is they're trying to get you to go to the cheaper version of a drug. It doesn't always work, but that's some of what's going on here.
Well, that's true. Go ahead, Mr. Fuchs.
Thank you, Madam Chairman. So as you both definitely pointed out, those tools are important from the health insurer perspective to really kind of, on the one side, try to control prescribing behavior. So really trying to get physicians to do those generic substitutions. But on the other hand, they also function as leverage. So the PBM will be able to exclude a drug and then go to the manufacturer and say, hey, you know, if you don't give me more rebate, you know, we're going to, you know, kick you down to a lower tier or cut you out of our formulary entirely. So there's kind of two functions of those tools. One is obviously trying to get those most cost-effective drugs being prescribed, but at the same time, they're also being used on the rebate side. So you see on the left, that negotiated rebate, they're the sort of the sticks that are being used in the negotiation. So they serve a dual purpose. The actual price paid, I think, there's no actual one price. I think what's interesting to show about this diagram, there's no one price of drugs. Everyone sees a different price. The wholesaler, for example, they see what's called the average manufacturer price. And these are, of course, this is a simplified diagram, believe it or not, of kind of how complex things can get. The wholesaler's average manufacturer price, they charge the wholesale acquisition cost to the retail pharmacy. They actually will pay this full AMP and then receive a sort of form of rebate called a chargeback. And so the wholesaler does various services for the manufacturer by buying, taking on the inventory risk and doing a bunch of other things. And so they get this chargeback. And the price to them is you have to actually subtract the chargeback from that AMP to get their effective price. The retail pharmacy, of course, they see the wholesale acquisition cost. And then the PBM, they see this negotiated price, and they negotiate not only on the dispensing fee for the pharmacy and all these other potential rebates and fees between the pharmacy and the PBM, but the vast bulk of those negotiations actually happen with the manufacturer directly. And that's where you see that negotiated rebate coming in. So their price is really the overall price for the drug less the rebate. And then, of course, there's a lot of controversy right now about PBMs not being less than transparent about how much rebate they actually give back to the health insurer clients. So I see, you know, on this diagram, the sum of rebate, some of it goes back to the health insurer. How much exactly is not necessarily known. And they certainly make most of their profit, most of their money off of that's the spread between what they negotiate with the manufacturer and what they remit to the health insurer. And then, of course, on the consumer side, consumers as a collective fund the health insurance system by paying premiums. So you see the large arrow going out. But then, of course, they pay smaller amounts, the cost sharing to both the physician and the pharmacy when they purchase the drug. And then finally, you'll see the dashed blue lines. This is interesting, and it doesn't happen all the time, but manufacturers will try to influence both prescribing behavior and consumer behavior by making various payments on the side. So physicians, approximately half of physicians in the US have reported receiving some kind of remuneration from, pharmacy manufacturers, whether that's in the form of consulting fees or free meals or travel arrangements or consulting fees, speaking fees, that kind of thing. Those are obviously intended to influence prescribing behavior. And then, of course, you have to consumers, whenever you see a TV ad where they say, GE Enterprises, if you can't afford your medication, GE Enterprises is happy to help. What they don't mean for indigent clients who don't have insurance. They mean for people with insurance where their cost sharing is high because the PBM is imposed high copays because they don't want that drug being purchased. And what they'll do is they'll basically send people a coupon and say, here's, we're going to reimburse you for that cost sharing. So you can buy our drug anyway. And so the real goal of that is to subvert the incentives that the PBM and the insurer have put in place for consumers to really go for lower cost and generic medication. So all that kind of influences, what gets paid for and what the effective price ultimately is. It's just a very, very complex ecosystem, I think, and you don't really know what the true cost of the drug is unless you really consider a fixed point of view. What's also interesting is that for Medicare Part D, we're normally used to Medicare setting rates and sort of being the single payer type system. Medicare Part D is very different. Medicare Part D was really set up as sort of this private side system. And so Medicare is actually statutorily prohibited as a program from doing any of the negotiations with manufacturers. So in a sense, it's very similar. On the private side, these Part D providers just have a Medicare book of business, and they do similar negotiations for their Medicare Part D clients on the price and the rebate they get. And that price is a function of negotiation. It's not a fixed. There's no one saying you have to this is what the price is. There's not really a list anywhere. It's very flexible, and it's a function of the rebate they receive. And those negotiations are the result of how much market share those Part D providers have, so how many covered lives they're negotiating with, and then how willing they are to use that market share to throw their weight around, so to speak. And really that comes down to saying no, and that comes back to those utilization management tools like having a formulary or having various tiered copays and cost sharing arrangements. That's what they use to negotiate in these discussions with manufacturers. So again, it kind of goes back full circle to these tools being the stick that causes this rebate and the degree of rebate that affects the overall prices, health insurers, and PBMC for drugs. When it comes to Medicaid and other payers, so Medicaid is unique. There's the Omnibus Budget Reconciliation Act, or OBRA, basically introduced this concept of a best price. So Medicaid receives the best possible rebate on any drug by law. And that makes it good for Medicaid, but it does create complications because when you're negotiating as a non-Medicaid provider, if you're a Medicare Part D plan or a private plan, manufacturers are never, they can't give you any more rebate below that, what the best price is, lest they trigger that provision, and they have to give that same price to every other Medicaid plan in the country. So it almost sets like a floor for what the price has to be for other payers, because the Medicaid volume is obviously considered, when you consider it on a national scale, is huge, and so having to give that best price to every Medicaid program, can hit the pocketbook of those manufacturers pretty hard. Now, the deal that Medicaid has made here is that we get that best price, but we do have to cover every single drug that's really the FDA has approved. And Medicaid can impose some kind of preferred drug list. We can kind of structure, how, the incentives for providing those drugs, but we can't just say we're not going to cover that as part of this deal. And I think when you look at this this table here, you see the impact of rebate. So nominally, if you look at, for example, the Medicaid annual report or our PMPM reports, you'll see that we spent around $60 million on pharmacy. The first thing we carve out of that are all the IHS related expenditures. Those are not eligible for rebate, but those are matched at 100% federal funds. So that's about 14 million taken out, which leaves about $47 million available for rebate. And the rebate, the best price rebate, pretty much cuts that in half. Then there's also this concept called supplemental rebate. So Medicaid programs, and this kind of goes to the group purchasing a bit, can sort of band together and negotiate additional rebate using those preferred drug lists and other utilization management tools as sort of sticks. Medicaid is part of the Sovereign States Drug Consortium, which is a very large purchasing consortium, makes up 13 states and 10 million covered lives. And you can see that we get an additional $2.4 million in supplemental rebate there. So when you consider everything, being the net pharmacy expenditures are almost a third of what the gross pharmacy expenditures are for Medicaid. And it's very hard to do better than this in terms of drug pricing. Finally, moving on to the VA, I think the VA is a very unique payer out there and very unique different from the other payers, Medicare, Medicaid, and the private side. And they have additional statutory and structural advantages.
Madam Chairman, Senator Scott's trying to get your attention.
Oh, I'm sorry, Representative Sweeney.
Madam Chairman Scott.
Madam Chairman.
Chairman Scott, yes, sorry.
I would like to just know what IHS stands for.
Mr. Fuchs.
Madam Chairman, Co-Chair Scott, that's Indian Health Services. Sorry, I should have clarified that. That's and all the tribal providers. It's reimbursed 100% federal funds.
Okay, go ahead, Mr. Fuchs.
So continuing on, Madam Chairman, just briefly touching on the VA. We don't really, obviously can't control the VA. We don't interact with the VA too much, but they do there's some interesting principles that come out of this. So when you look at the VA, the VA payment system, they not only have very strong statutory advantages, they have these guaranteed minimum prices, but they're also exempted from the Medicaid best price calculations. So the VA can actually go below Medicaid rates as far as rebate without triggering all the manufacturers having to pay rebate to all the Medicaid programs. So that gives them some negotiating leverage as well. But they also have some structural advantages. I mean, they are effectively a socialized medical system. They own all the doctors, they own all the pharmacists. And so what that allows them to do is really try to enforce more coordination on the prescribing behavior. Unlike the private market examples where everyone's sort of the physicians are sort of free agents. The physicians here are really work very closely with the pharmacy services. The pharmacy services can do generic substitution. There's a very strict national formulary. They're pretty mean about what drugs they can exclude from that. And I think that goes to Chairman Wilson, your point about, a formulary is a very effective means of negotiation for cost, but it does have some significant implications with respect to access to the consumer. So if you're a VA customer, you're going to have a very limited set of choices of drugs that, in various therapeutic classes versus, on the private side or Medicare. So those kind of structural advantages really help it get basically some of the best and lowest drug prices in the country as a payer. So all this sort of comes back to, this main slide here. This is kind of these payment principles. How you buy the drugs affects how much you pay. And I think there's just three basic ideas here. The more purchasing power you have, the more leverage you're going to have. But you have to be willing to use that leverage by saying no to drugs. And I think the lesson here with respect to, the various tiering and cost sharing is that formulas are going to be more effective because they can't be subverted by manufacturer coupon programs, for example. But of course, that saying no has implications for choice and access. So there's no real free lunch in this sense. If you're going to be really strict about what drugs you cover, there may be fewer people that are willing to sign up to your plan. So that might affect how much covered lives you have. So there's kind of some interesting duality, dynamics here. But I think finally, coordinating with physicians and trying to bridge the gaps, the information gaps between physicians, pharmacists, and the consumers, I think is another effective tool to really try to improve prescribing behavior and get the most cost-effective drugs you can. So I think these are kind of the three key lessons, at least I've learned from this, looking at these sort of ecosystems that I think would apply to any drug purchasing program that the state would be trying to set up. And I have a Walmart slide in here. I'm not trying to promote Walmart, but Walmart is on the consumer side the epitome of those first two principles. Walmart has massive market share. In many cases, for any given supplier, whether it's Huffy Bikes or Vlasic pickles, Walmart will be 20% of their volume in many cases. And so they have that market share, and they are not shy about pushing on their suppliers constantly to lower costs. Every year demanding 5%, off, the previous prices, and really trying to push for efficiencies on the supplier end. So they are kind of an example of, on the consumer side, they're not obviously a PBM, but that's kind of a shorthand way of kind of communicating those first two principles of having market leverage and being willing to use it. So with that, we consider the three major proposals that were studied in this study. And the Canadian drug importation, these slides are actually not that different from what you saw previously. We do not recommend pursuing this option because while there are these genuine price gaps, there's a lot of complexity in those payment systems. So for example, when we talk about Medicare Part D, we would have to get that Canadian drug on the formulary and covered by, at least the 5 major insurers that provide Part D plans in Wyoming. And there's no guarantee that we can say, you have to pass all those savings on to the consumer in terms of cost sharing. They're probably going to require some kind of cut of the difference in the prices. So we can't guarantee that, the consumers will actually see cost savings at the end of the day, if you can even get it on those insurer plans. And at the end of the day, I think there's a very strong economic argument that kind of basically, this idea of arbitrage and price discrimination, that this is really not sustainable. If we were to try to exploit this, little old Wyoming doing it by itself, that might work for some period of time. I think that volume is small enough that you probably could do it. But we're behind Florida, we're behind Colorado and Vermont in terms of trying to set these Canadian drug importation programs up. And I think as that volume, the more volume you get, the more this effect becomes noticeable. And as you heard from both the person who participated in your meeting, as well as that letter that was sent to us by the Canadian consulate, they obviously would have concerns about access in Canada. Even if the Canadians, however, didn't impose export restrictions, it's conceivable that drug manufacturers would see the problem with their, losing revenue and impose restrictions of their own. So there's two actors, both the drug manufacturers and the Canadian government, that would have an interest in shutting this down if it were really exploited at scale. So for those reasons, we do not recommend pursuing the drug importation option. We have a couple other slides here. We kind of talked about this before. This is kind of an example of the face value potential savings with one particular example. I've revised downward. We found a couple items on our list, on the EGI list, that were actually biologics or controlled substances. So I know I said 10 million before in face value savings. It's now down to about 8. Still a significant number. Obviously worth exploring. In the study itself, and I don't have slides about this, but we talk about kind of the logistics of the various options we would use to distribute these drugs. So say we somehow, this is all working fine, we're importing pallets of drugs from Canada. One option for in-state logistics is using the liquor division. I think there's a lot of actual, potential efficiencies here, because they already distribute liquor throughout the state. And since there's about 10 times as many liquor retailers as there are pharmacies, it probably would not impact their distribution routes that much to drop off the tote of pharmaceuticals at the pharmacy store or the pharmacists, and then continue on their liquor delivery route in various towns throughout the state. So they already have the infrastructure for breaking down and stocking pallets and all that stuff. They already have a system for ordering liquor. A lot of these things can be leveraged to really do this for Canadian drugs, assuming you really wanted to get it out to those retail pharmacies around the state, which is kind of a specifically mentioned in this study. On the other hand, there's another option that we consider. This is page 36 of the study. We're looking at sort of a mail order option. And if this was really trying to exploit just for the employees group insurance, a more efficient option would just be doing a mail order pharmacy run out of the basement of the Hathaway building with the medication donation program and plussing them up a bit. We believe we could do this, depending on which program you wanted to pursue, at somewhere between $1.1 and $2.8 million for in basically a one-time and annual cost for the first year in setting this up. Obviously, we'd also have to buy the drugs, and we're estimating approximately $12 million for all the drugs in those tables that we have in the study. So there would obviously be some upfront costs, but we would recoup those costs in revenue, presumably as sort of a tack-on charge to the retail pharmacies, and recoup that revenue. So really, it's more of an appropriation figure, not necessarily an ongoing expense figure. At the end of the day, however, when we're looking at Medicare Part D plans, which obviously older folks tend to consume more drugs than younger folks, and Medicare is kind of one of the biggest markets for pharmaceuticals. When we look at the cost sharing, it's a lot less. The potential savings, and there's of course a lot of complications. So I already mentioned those. Here's kind of the market share for Part D plans. So starting at the bottom with Humana being the largest and moving up, you'll see that just to get 85% market share, we have to negotiate with those 5 bottom healthcare insurers. And of course, you'd be leaving some seniors out unless you went with all 10 or 12 or whatever on this list. So again, it's really hard to guarantee that consumers would actually see those savings. And consumer savings is actually one of the main requirements for applying for this program to begin with. So saying we're going to save EGI $8 million would not be a rationale that would, I think, fly with HHS. They have to see, some kind of savings to the language specifically states savings to consumers. So EGI would really have to just, do some cost sharing reductions or something to make that work. It's probably possible to make it work, but I think that the focus of the legislation on the federal level is really looking at the consumer. So we have to keep that in mind as well in designing this program. But of course, I think there's some really significant economic problems with this. We talk about, why are the Canadian drug prices lower? It really comes down to this idea of price discrimination. It makes sense for the drug manufacturers to sell to Canada once, those if the Canadians are willing to pay above the marginal cost of production. So there's 2 different kind of concepts here. The average cost of the prescription includes all those fixed costs. But once those fixed costs, say you're designing it for the US market, you've introduced it in the US market, you're selling it here, what it costs you to produce an additional pill is your marginal cost. And you've already paid for those fixed costs. The marginal cost is really just the cost of the ingredients and all the labor it takes to package the drug. And that's going to be significantly lower. Again, remember that fixed costs are 2/3 of the average cost of a prescription, right? So if you're really just looking at those variable costs, manufacturers are going to be willing to take anyone who pays more than that marginal cost, assuming that they've already sort of introduced it in the US market and are getting, paid those fixed costs covered through the US market. So it does make sense for these manufacturers to do it. The key is that they have to be able to discriminate between Americans and Canadians. And if you have a Canadian drug import program, that sort of does away with that ability to really kind of tell the difference between those segments of the market, and can potentially, obviously in the long term and at scale, lower the revenue until they figure that out. So I have this cute analogy of, I guess, the 2 kids in a trench coat thing doesn't make sense for adults trying to buy senior citizen tickets to the movies. But that's kind of the analogy here. We see price discrimination everywhere even as something as simple as going to the movies. So hopefully that's a good analogy to kind of explain, what the problem is with importing drugs across the border. So at the end of the day, of course, another update from the previous presentation is that we got this letter from the Consulate General. They of course expressed concerns about this idea. You heard those concerns again from the I think representative of the Canadian Society of Hospital Pharmacists that testified, and they have the same concerns, which that if we did this at scale, I think it would certainly affect access, and Canada would quote, be forced to respond to any actions that can endanger the health and safety of Canadians by threatening the supply of prescription drugs or causing the cost of prescription drugs for Canadians to increase. So with that, I'm happy to take any questions on the Canadian drug import thing, or I can just plow right ahead and finish this presentation up with the group purchasing and subscription model. I just have 2 slides on those.
Why don't you, Franz, why don't you just go ahead and finish the slide deck? And then we will take questions on things in general.
Yes, Madam Chairman. So when we looked at group purchasing, we were looking at this from the perspective of getting payers within the state together. And again, we don't believe this will materially affect costs within the state if we were, to do this within the state, just because Medicaid is really the biggest purchaser of drugs. But because of that unique statutory position with the rebate, we can't commingle this purchasing power. We can't get rebate by including non-Medicaid drug claims into that negotiation. So Medicaid really has to negotiate by itself by law. And then once you exclude Medicaid, you're looking at DOC and sort of non-Medicaid cats and dogs around the state. It'd be a very small group of, maybe 2,000 to 3,000 covered lives. And, DOC spends $1.7 million total compared to $60 million that Medicaid spends. Just, I think, shows the scale of who's left. Excuse me, Madam Chairman. Our building is very, very well ventilated to the outside, but unfortunately, the outside air is we're getting a little bit of that Mullen fire coming into my office, so I apologize.
Yep.
At the end, I think what's more important than that 1.7 million figure, though, is the DOC spending on any given drug, because the negotiations aren't happening as a function of your total drug spend. They're happening individually on a drug-by-drug basis with each of those manufacturers. And that individual total, that maximum is $180,000, which is pretty small. Finally, there's 2 points. One is that, of course, their current health services contract is all inclusive, so they wouldn't be able to separate the pharmacy out from that. But of course, Director Shannon testified to you that they are looking at reprocuring that next year and possibly separating that out. And then finally, the result of any actual discounts, if we were to do this, it's really, again, the subject to negotiation, so we can't speculate on what those potential savings might be. And then finally, the subscription model, again, we covered this briefly. I apologize, Madam Chairman. Let me mute myself while I hack a few minutes in my office. Okay. This kind of model, again, really is intended to, these states that are pursuing this, which are Washington and Louisiana, they call this the Netflix model. They call it the subscription model. I call it an all-you-can-eat buffet. But basically, it's, you pay a set minimum price, negotiated price for all the drugs you can eat. And the real goal here is eradication. It's not necessarily short-term cost savings. And additionally, because these are relatively new, and because the arrangements around these contracts are pretty secretive, nothing's really been publicly released. We don't even know if they're saving money on a per script basis. That may be possible, but generally speaking, it seems like they're setting the baseline at what their current budget is, and then looking at a sort of de minimis amount for all the drugs they can buy after that fixed minimum. Again, with the goal of eradication. So, because of that, we recommend against pursuing this option, unless the state were to pursue a goal of eradication, in which case it might make sense.
All right.
And with that, Madam Chairman, happy to take any questions.
Great. I think we can probably have you stop sharing just so I can see all the people whose hands might be up. You may end up having to put it back up if there's something specific, but questions for Mr. Fuchs. Senator Scott.
Madam Chairman, not a question, but a comment. I want to compliment Franz on his usual excellent work. This is, I think, in my judgment, a very well done paper, one of the best I've seen in this area. And I just wanted to publicly extend my compliments to him for the quality of the work that he does.
I second that.
Thank you, Madam Chairman. Thank you, Mr. Co-Chair.
Any actual questions for Mr. Fuchs? Okay, well then let's just detour before the Department of Health. Elizabeth, was there anybody who wanted specifically to testify on the drug importation study?
Yes, ma'am. We do have 3 individuals who would like to provide public comment on this specific study.
Okay, let's hear from them.
All right, the first individual we have is Mr. Byron Odekoven.
Aha. I see his black rectangle. Welcome back, Mr. Odekoven.
Thank you, Madam Chair.
I was just going to ask first in jest, as you're in the law enforcement community, we did hear that the government of Canada might feel that they needed to take steps if we were to pursue this. You've not heard of any massing of the Canadian military on the Montana's border or anything?
No, Madam Chair, I have not.
Okay, well, keep your ears open just in case. Go ahead, Mr. Odekoven.
Thank you, Madam Chair. Byron Odekoven, the Executive Director for the Wyoming Association of Sheriffs and Chiefs of Police. Again, offering a thank you to the committee. You were very receptive to our concerns on safety for the drugs that may be coming from Canada if this were to go forward, from those who would exploit the process and may bring some of those illegal or fraudulent kinds of drugs in under the guise of the program that we would establish. But again, thank you for listening to those concerns. I believe it has an overall bearing on the process if you were to choose to go forward, but it appears as though it's not worthwhile on the actual cost side. So we wouldn't have to be worrying about those exports of fake drugs, if you will, to the United States. So with that, Madam Chair, again, thank you for allowing us to offer comments earlier on the safety of the process of importation.
Okay, questions for Mr. Odekoven? Okay, great. Thanks very much for participating.
I think Representative Barlow was raising his hand.
I beg your pardon. Representative Barlow.
No, thank you. Thank you, Madam
Okay.
Chairman.
All right. Okay, Elizabeth, who have we got next?
Ma'am, next we have Andy Somerville.
Okey doke. Ms. Somerville, are you there?
Ma'am, we also have one other individual if we would like to admit them while we wait for Ms. Somerville to appear.
Oh, okay, that's fine. Just send it in. Who is this person?
Craig Frederick with the Wyoming Pharmacy Association.
Oh, okay, that's fine. As soon as we can get Ms. Somerville in, and we'll tee her up, and then we'll leave Mr. Frederick in the, what do they call it? The batting box or something, or, sorry, I'm not really a baseball person. On deck, I guess that's what they call them.
Ma'am, I have admitted both Andy and Craig Frederick. It does appear, however, that neither is available at the moment. Just a moment. Oh, there is Andy.
Oh, there you are. Welcome back,
Hello.
Ms. Somerville.
Well, thank you, Madam Chairman. Andy Somerville with WAMSAC. I just signed up for public comment.
I admitted both Andy and Craig Frederick. It does appear, however, that
I apologize. I just signed up for public comment to provide any information the committee might have been interested in regards to mental health and substance abuse that you received from Director Shannon from DOC. I don't really have any additional comments unless anybody has any questions. I think he covered everything pretty well.
I thought just does occur to me, just for building up my knowledge base, the mental health centers when there are patients who are uninsured, do they dispense any medications at all, or are the patients sent to FQHCs where they can access the federal pharmacy programs, or how might those people get their meds?
Madam Chairwoman, so it works in a variety of ways. The community mental health centers for medications are generally only involved in the MAT therapy program. But in terms of making sure, especially for the psychotropic medications for our mental health patients, they do pay for those sometimes out of quality of life funds for those that don't have the ability to pay for them. And then they would receive those from a local pharmacy. So there's a few different ways that we try to make sure that the patients stay on their meds.
So, well, I'll just inquire locally. I mean, it does strike me that person that might end up being a kind of a significant cost to some of those. I don't know how much the psychotropics cost, or if they're all generic. And FQHCs are not located everywhere as far as, what is that program called? 1B, 43B, some number and letter program for the pharmacy. Interesting. Well, we'll save that for another day. No other, any questions for Ms. Somerville? All right, thank you.
Thank you.
And I see Mr. Frederick. Welcome aboard, Mr. Frederick. If you'll just identify yourself and let us know what you would like to tell us. And you're still muted. Okay, we see you.
Hello, can you hear me?
I can.
Well, I'm unmuted and I'm only Somerville sure ahead of me.
So, Mr.
Sure she
Frederick,
is.
we're having some lag with your internet there. If you're listening to YouTube as well, if you shut that off, that might help. I don't know. I'm not really not an IT person, but I'm not sure where you're calling from. Try again.
I had no problem listening to everything on YouTube, but now that it's on Zoom, then I'm struggling to keep up.
We're struggling to hear you, but speak slowly and maybe we'll decipher it.
Can I just call in?
Yeah, that works. Elizabeth, if you'll work with him to be able to for him to call in.
Yes, ma'am. He should already have that number as a part of the Zoom invitation that we sent to him, and he can just call that number and we can let him into the meeting.
Okay, did you hear those instructions, Mr. Frederick? So if you close out your Zoom connection, Mr. Frederick, but look on the email where you received the Zoom link, scroll down farther.
And I cannot understand.
Representative Yin, is there any assistance? Because I've had the same problem trying to get into meetings on different. So.
Madam Chairman, I would suggest what you suggested, which is to call in at this point. I think there's not a lot of troubleshooting that we can do on the fly here.
Representative Yin is our committee IT designee. So it looks like Mr. Frederick has closed out his Zoom there, and we'll see if he's going to call in. We'll give him a few minutes.
Madam Chairman, if I may, while we have a moment, while
Please.
Mr. Frederick, I'd like to ask Mr. Fuchs about, so in the report, it noted that one change could be, I know we hear about this a lot, Medicaid expansion, especially given the amount of advantage that Medicaid has in leveraging negotiations with prescription drug prices. Did he have a chance to model, if we expanded Medicaid, how much out of cost savings would it give to the state's citizens on average, or maybe just those particular citizens that we would expand the Medicaid population into? If Mr. Fuchs is around.
Madam Chairman, Representative Yin, we did not specifically do that for this study. I think, as always, we will update our Medicaid expansion study with updated projections. And I think that would be an interesting topic to look at the prescription drug side of things. I think we focused more on the inpatient and outpatient side last time, but I think we can certainly try to answer that this fall.
Mr. Fuchs, I think that would be a good, if we looked at, you know, I don't know how far down you can drill into your demographics, but the over 65, well, actually they wouldn't be included. So, you know, but the people between, say, 40 and 65 who are, you know, if you can get information about that without undue effort and determine what the out-of-pocket costs, and that would be an interesting little addition.
Madam Chairman, we do have good national data based on the medical expenditure panel survey. It's not Wyoming specific, but when we did that, we considered including some of that for this study. The two main patterns that stood out to me with respect to out-of-pocket and drug utilization generally was that, you know, obviously senior citizens were high on the list, but also uninsured between, you know, the ages of 30 and 50, you know, increasing up to Medicare eligibility age. So we can certainly try to include that.
Well, and you could look back on the previous report from the multi-payer claims database. I mean, one would assume that the distribution of prescriptions and all that would not change significantly over the course of a year. So even though it's old, you know, a year or two old, I think it would still, because if we were higher than Montana. I don't know where Montana is as far as the national average, but you could make a plug figure. Let me just check in. Mr. Frederick, are you there yet? Elizabeth, any report on Mr. Frederick's status?
Ma'am, I believe we are working with him at the moment. Katie, do you have anything extra?
No, I did try to,
Okay.
Madam Chairman, I did try to call and invite him, but perhaps he's on now.
Well, it's not letting me, it's saying I can't start my video. Can you hear me?
We can hear you, Mr. Frederick.
Okay.
So that should work, and we can hear you quite well.
Okay. Well, thank you all. Oh, can see me now too. All right.
Yeah, there we go.
All right. I sincerely apologize for those technical difficulties. Thank you. My name is Craig Frederick. I'm the Executive Director of the Wyoming Pharmacy Association. I first want to thank the legislature for even taking up this subject, especially my thanks to Representative Salazar and Representative Barlow, who both had bills in this area in the last session. I also want to give big thanks to the Health Department and Franz. I can't echo you guys enough about how well this study was done. I've looked at a lot of these through different states and whatnot, and this one is very comprehensive, and I really appreciate all the work that they have done in getting that information out to us. In my presentation today, I did want to talk a little bit about importation, but I think that is mostly taken care of itself. And I just want to say that in general, the Wyoming Pharmacy Association is opposed to an importation program at this time. I'll just leave it at that for now. The second point I'd like to discuss deals with pharmacy benefit managers. And I think it's very fitting today as the Supreme Court is actually listening to oral arguments in a very landmark case in pharmacy, Rutledge versus PCMA, in regards to PBM practices in a lawsuit that came out of Arkansas. So that'll be interesting to follow. It's just a little side note. But if you look at the flow charts on page 12 or on page 17 of the Department of Health report, and again, from that report, I love the flow charts and those different things. I think it really shows the complexity of the pharmacy payment system. You know, it wasn't too long ago, well, maybe a while ago, but it was just a much simpler system. There's a lot more players involved, and I think that causes issues. But I find it fitting that if you look at that model, that flow chart, that the PBMs are located right in the middle of this diagram, as they are in the middle of everything in retail pharmacies. Over 90% of prescriptions that are dispensed use a third party for payment. You can see that the PBMs have agreements with insurers, pharmacies, and manufacturers, all of them. This allows them great power and control in pharmacy payment systems. Rather than being administrators of prescription claims, although they definitely do that, don't get me wrong, and facilitators, I believe that they have become revenue producers for shareholders, and in doing so have continued to find ways to pay pharmacies less in some practices, or even forcing pharmacies to pay the PBMs. Over the last number of years, the reimbursements of pharmacies have declined year after year after year, while the costs of doing business continue to go up and up. PBM-owned mail-order pharmacies have been created, which are deemed to help as far as cost procedures, but it definitely hurts the local pharmacy. DIR fees, which are retroactive fees pharmacies pay PBMs, are on the rise. They seem to be going up and up as well. Some PBMs also use clawbacks, and PBMs even charge pharmacies a transaction fee to submit their claims to the PBMs. And that fee itself continues to go higher and higher and higher on each specific claim that we submit. These practices that are intended to save patients money are seriously affecting access to care, especially with Wyoming's rural nature. These practices are hurting the economy of Wyoming with loss of businesses and loss of jobs, as pharmacies are having a more difficult time to stay in business, and this certainly affects the access to care. There's one point that I'd really like to clarify, or at least add to, in the health department report, and that comes on page 19. And Mr. Fuchs, in the very top of page 19, even today he talked about spread pricing. And in the report and in his testimony today, he stated that spread pricing dealt with the rebates. And there is possibly some spread pricing that deals with rebates. I don't dispute that fact. But however, spread pricing goes far greater than just the rebates. Spread pricing is really the difference between what a PBM reimburses the pharmacy for dispensing medications and what the PBM charges the insurer for dispensing the medication, if you will, for facilitating the testimony, or for facilitating the transaction that takes place. So that's where the spread pricing issue comes up. And we feel that this area is oftentimes exploited by the PBMs, as it was seen in 2018 when it came out of the state of Ohio in their Medicaid program. So, and unfortunately, due to proprietary trade secrets, the words and terms that they really like to throw around, it's really difficult to tell what sort of spread pricing practices are going on. However, like I said, in Ohio in 2018, some of that was greatly exposed, showing some times where PBMs seem to have overstepped their boundaries in using spread pricing. So again, I just want to point out that spread pricing is maybe dealing with rebates, but it mostly is a part of the difference between what's paid to the pharmacy and what they charge the insurer. I believe as legislators, as those elected to essentially oversee all of your state employees, the Medicaid program, that you deserve to know what spread you're paying. We certainly believe that PBMs need more transparency throughout this process. So enough on that. So my last part, believe it or not, with a lot of this maybe doom and gloom, is I want to talk about some possible solutions. And solution might be a grand word, as it's going to be a step-by-step process. It's taken time to get us to the point we are, little by little, and pharmacy is the worst at this. We were always giving a little, giving a little, giving up a little, giving up a little, and then all of a sudden we find ourselves in the great hole that we are. And I think a solution is going to we need to take the same approach when we look at solutions. We're not going to find some great way to get us out of all these rising drug costs. And so from the discussions that we've taken place along those lines, it seems as though we feel, and it really came out in the session last year, or last month, or in August, the last meeting, that maybe a lot of the pricing issues have to deal with that need to be fixed on a federal level. So I'm looking at what can the state do? What are some approaches that the state can take in order to help save drug costs? And I believe that can be done in two ways. First is by implementing preventative measures and programs that can help keep patients from needing as many drugs. It came out a little bit in the August meeting that really the way to lower drug costs is to basically not use as many medications. The second way is by optimizing patient drugs regimens, the current regimens that patients are on right now. How do we optimize those regimens in order to save money? And believe it or not, pharmacists can help in both of those areas. Pharmacists are educated and trained to do both of those things. With an understanding of medications, as well as having access to the economical resources in regards to medication regimens, we are the perfect fit to ensure both positive health outcomes and improved fiscal return to insurers and patients. The program that Senator Scott referred to in the August meeting, the pharmacist program, was an example of one of these cost-saving measures that unfortunately went by the wayside. It's a program similar to that I think is a way to certainly decrease the amount of drug costs for all of the people that you serve, and whether it be the employees or Medicaid program. So pharmacists right now are working closely with the Department of Health and some preventative programs, things through the chronic disease health area. And we're beginning to work with them and how we can talk to members, people in the general public, just ways that the Department of Health is utilizing preventative measures. Also, our services, we'd also like to offer our services as pharmacists to provide comprehensive drug regimen optimization, also known as MTM or medication therapy management, how we can offer our services to any insurers who believe that would be a benefit to their patients. So as I offer up and say that pharmacists can help in this situation, we do have a few hurdles. In order to do this and in order to be reimbursed, not even appropriately, but in order to be legally recognized and reimbursed, there needs to be some laws and rule changes that allow pharmacists to achieve that goal. One thing I believe is that we need to work towards having our technicians be more involved, allowing pharmacy technicians to have a greater role in the dispensing process. And in the dispensing process, and that leaves more time for pharmacists to do more of the clinical care and the optimization of drug regimens. And also, pharmacists need to be recognized as providers. Right now, if I were to see a patient, unless I have a direct contract with an insurance company, it's very difficult to get any reimbursement as we're not recognized as providers. So we can work under a provider through a doctor or that sort of thing. We have to kind of work under them and charge basically through them or through a clinic for any of our time. But I think if we can get recognized, then there are ways that we can pursue help in that area. And again, we can spend time with the patients. We can optimize their current drug review, or review their current drug and optimize what they're on, as well as utilizing preventative measures to help the state save money in this problem we're facing today of the rising cost of drugs. And with that, and through all the issues, I stand for questions. And I can't hear.
I actually muted myself.
Okay.
Question, Senator, Chairman Scott.
Madam Chairman, question. Is there any legal barrier that we need to remove, Mr. Frederick, for pharmacists to be able to go out and market their services in this area? I'm thinking particularly of large employers, because the cost savings are certainly there and possible. We saw that with the pharmacist and program, and the reason that one went away was it was marketing to the seniors, and when the federal government brought Part D in, a lot of the people lost their interest in that, and we didn't have enough customers. But where you're talking about your customer being a large insurer, and I would start in the private sector, are there any laws that we need to change so that you could go out and sell those services, your services to those large employers and essentially compete with the PBMs?
Mr. Frederick.
To my knowledge, there aren't really any legal barriers other than being able to, like I say, bill for our services and them not utilizing that. We are covered through insurance, our insurance policies that are done either as an individual pharmacist or through companies. They cover that sort of thing. So I really don't see any real legal barriers that say a pharmacist can't go and meet with the patient and do this sort of review.
More questions for Mr. Frederick. Representative Barlow.
Thank you, Madam Chairman. So when I look at the definition of healthcare provider in Title 33, it specifically includes pharmacists and pharmacy technicians. It includes veterinarians too, just so you know. And so, but the only place I know in statute where we actually line out particular services within the context of a program is within Medicaid in Title 42. So I haven't got to look it up yet to see whether pharmacists, as far as a service provider, is included, not just pharmaceuticals, but the pharmacists themselves. So maybe Mr. Frederick could speak to the Medicaid component if he knows of that. Thank you, Madam Chairman.
Mr. Frederick.
Yes, Madam Chairman and Representative Barlow, I do not have that in front of me, but I do believe that that is where the hurdle is. I do believe that we are listed as providers in one area. However, in the reimbursement form with Medicaid, we are not.
More questions for Mr. Frederick. You know, following on the questions from Representative Barlow and Chairman Scott, I feel a little bit like we're running out of time in this year's interim, but it does seem to me that next year's interim topic list, we might very well kind of follow on from this prescription drug study and consider PBMs, just in general, PBMs in the state, the employee group insurance, ways to optimize. You know, you referred to it as MTM, but I'm thinking sort of a case management type thing. You know, scope of practice as far as pharmacy techs, maybe bring in the School of Pharmacy. I mean, we could really have sort of the pharmaceutical side of things be an interim topic more broadly, and maybe carry that on to there. You know, I mean, obviously, if people have interest in some sort of individual bill between now and January, that's always available to people. But I would think that maybe sort of looking at some of the pharmacy things in the interim, and also the governor's healthcare task force is taking a look at costs there. Are you involved in that, Mr. Frederick?
No, I am not.
Okay. Anyway, I've put a star next to this on my notepad here. More questions for Senator Scott?
Madam Chairman, I would very much reinforce that, because we know that the sort of thing that Mr. Frederick was talking to us about, we know from our experience with that pharmacist program, we know from the experience that the pharmacist who brought that to us, he was employed by Admiral Beverage and he was saving them big time money. I think possibly looking at it in the context of the state employees program and we know the savings are there. We need a creative system where we can be able to employ them.
Right. Between that and Medicaid, and even though we don't have the multi-payer claims database available anymore, we've got like last year's data comparative. Just I feel like maybe a drill down in general into this might be a good topic for us. Okay, I don't see any more questions. Mr. Frederick, thank you. You've been very informative. And if I assume, are you listed in the Capital Club's directory so that we can find your email contact information or something? Or just at the very least, make sure to email into LSO so that we can track you down again.
I will do that. Thank you for your time, Madam Chairman, and the entire committee. Good luck with the rest of your day.
Thanks very much.
Thank you.
Okay, Stefan, we see that you have released yourself from the governor. Can you give us a sense of how long the department, now I don't require you to estimate how long the committee members will talk. That's always hard to estimate. From your end, the report on the budget reductions and the federal minimum requirements, about how long do you think you've got in there? I'm trying to decide whether we should send everybody off for lunch and come back, or just wait and come back for the COVID response.
Madam Chairman, Stefan Johansson with the Health Department. With the testimony from our end on the what the budget office called step 2 reductions, essentially the first 10%, I can go over that very quickly. Probably less than 10 minutes, and then subject to committee questions. You know, I would leave that to your opining on how long that would take. In terms of the Medicaid federal minimum requirements, I would say between myself and Jesse Springer, probably 15 to 20 minutes, and then subject to questions after that.
Right.
Relatively short presentations on our end, just really overviews. But happy to tackle those now or wait until after the recess.
Okay, so realistically, committee, and then Chairman Scott, I'm going to ask for your input on this. It sounds to me like if we go ahead with the Department of Health's reports here, even if we held off on public comment until afterwards, we wouldn't probably finish until 1. So we have, I think, the option of either breaking for lunch now and then coming back, hearing the Department of Health, taking public comment on their presentation, and then we want to look at the COVID-19 response. So we could either break for lunch now and then do all of that, or we could kind of divvy it in half. And Chairman Scott, do you have any thoughts?
Yes, Madam Chairman. The understanding the Medicaid requirements for maintaining federal match, that whole business of what can we do and what can't we do in Medicaid is sufficiently complicated. I know I have a number of questions in that area, just trying to understand it. So that will take some time. I think the breaking for lunch would be a good idea, at least before we get to that one.
Okay, that was kind of what I was thinking, because it's Department of Health pretty much again anyway. And sorry, Franz and Stefan, for having you hang around like that. But so I think, committee, what we will do, and we do have a few people that had to depart. I know there's some people had to go away for lunch. I know there's a few other people who have emailed into me that you had previous obligations. I mean, I think that we would be done about the time that we thought to anyway, but I know someone had to drive and that sort of thing. So let's go ahead and recess now for lunch. It says an hour on the agenda. LSO, if we come back at 1, I know that's only 40 minutes. Is that long enough for you, or do you want a little more time?
Ma'am, it's to your discretion how much time you would like to allow for lunch. We should be prepared if you do come back at 1.
You think 1 o'clock will work?
Yes, ma'am, we can make that work if that is your.
Well, I don't know. I'm sure it was Mr. Brody wanted the farthest away sandwich. I'm just gonna give him grief there. But he has his picture not on live anyway, so if he eats at his desk, we won't know. Okay, committee, let's recess for lunch and come back at 1 o'clock.